speakers, moderators, healthcare professionals, researchers, and dear participants for joining us in today's webinar on National GDM Day 2026 themed Focus on the Fetus for the Future. Well, gestational diabetes mellitus is not only a metabolic concern during pregnancy, but yes, also a very critical determinant of the long-term health of both mother and child. And platforms like this webinar allows us to bring together the experts of, or rather the stalwarts of clinical nutrition, diabetology, obstetrics, and research to share insights, evidence, and practical strategies for improving maternal and fetal outcomes. We are privileged to have an excellent and distinguished panel experts. We will discuss important aspects ranging from fitness during pregnancy and the interplay of PCOS, obesity, and GDM to management of GDM with preeclampsia and integrated postpartum care. And I thank all the collaborating organizations and speakers for their valuable contributions and all participants for taking the time to join us this evening. So let us begin this enriching academic fest and work collectively toward a healthier future for mothers and the next generation. And thank you and welcome once again. And before we start off with the session, we have our founding member, Dr. Mansi Patil, who is also a chief clinical nutritionist. And she is a member of the Regional Advisory Group, South and Central Asia International Society of Hypertension, and office bearer, committee chair, disparities in CVD, American Society of Preventive Cardiology. And also she has got several international affiliations, and she's also faculty at Maharashtra University of Health Sciences, faculty at Victoria University, Australia, and recently she's also a faculty of design thinking at Lumitech, Qatar. So I welcome you, Mansi, and would request you to please introduce our metabolic syndrome and nutrition core group and welcome the audience. Over to you, Dr. Mansi.
Thank you, Dr. Bijaya, for having me here. And thank you, Dr. Cheryl, for organizing this wonderful event on the occasion of Gestational Diabetes Day. And a very warm welcome to all the esteemed speakers. I think it's an honor to share the stage with all of you today. At Metabolic Core Group, basically it started with two different core groups. One was hypertension and one was obesity. But somewhere down the line, we realized that we need to come together to fight this epidemic of metabolic syndrome and be more be more inclusive of this whole story of the rising levels of diabetes, obesity, hypertension, and the likes. So today, with this webinar, I think it's a wonderful opportunity for us to talk about gestational diabetes, as Professor Bijoya mentioned. And we've I think this is something that we all realize, that almost when we say that 1 in 6 pregnancies are affected by hyperglycemia, then we know that gestational diabetes is accounting for a majority of cases, and women who develop GDM would have almost 7 to 10 times higher risk of developing type 2 diabetes as well later in life. And metabolic syndrome in itself nearly affects 1/4 of the individuals worldwide, and this is a growing risk for Indians as well. Nutrition, lifestyle will play a very major role. I will not delve into it because we have experts talking about it. And as nutritional professionals, the key role is in promoting early screening, maternal nutrition counseling, as well as long term lifestyle interventions, both for the mothers and future generations. So, without much ado and without taking a lot of your time, over to the esteemed speakers and the moderator for taking this forward. And once again, a very warm welcome from Metabolic Core Group of IAPN India and the torchbearers for this core group now, which are Bijoya and Cheryl. Thank you for being here, and all the best for the webinar. And I hope all of you who are viewing this would enjoy this a lot. Thank you.
Thank you. Thank you. Thank you so much, Dr. Mansi, for your introduction, for introducing our core group, and for being one of the flag bearer of this metabolic syndrome and nutrition and holding us all together. Thank you so much. So now, without much delay, let us start with the most anticipated sessions, as we are having such stalwart amongst us, and I take the privilege to introduce none other than Dr. Sunil Gupta, who is the National President-elect RSSDI Headquarter 2026 and National President of Diabetes in Pregnancy Study Group India, DIPSI, 2021-2022. He has got an Excellence in Healthcare Award in 2025 at Nagpur Then National Foxy Dr. DC Datta Award 2025 at Mumbai, Award of Excellence in Academics 2024 at Omkareshwar. His key awards also include the only diabetologist of the country honored with the Outstanding Young Person of the World 2002 award in USA. And name has also been included in the Guinness Book of World Record 2013 and Limca Book of Records 2016, Asia Book of Record on January 2026. Heartiest congratulations, sir. And we are having, like, I take this privilege to say a few words about you. And you are such a respected person, and all of us are looking forward to hear you out. You have been a flag bearer in the research as well, and have published 239 articles, book chapters, and abstract presentations in various international and national journals, conferences, and has conducted total 3,439 programs in last 31 years. That is 110 programs per year average. My God, I seriously don't know like how you are managing, and you are a true inspiration. And along with that, you are also an associate editor with International Journal of Diabetes in the developing countries. So the list is endless. And over to you, sir. We are so looking forward to listen to you. Over to you.
Thank you very much, Professor Bijoy and Dr. Mansi. Can I upload my slide? Will you be able to unshare your slides so that, yeah, okay. Yes. Hope my slide.
Yes, sir, slides are visible. But it seems there is some network issue at your end.
Yeah, network issue seems.
Am I audible now?
Yes, sir.
Or little still? Okay, great. So wish you all
Voice is cracking, sir.
a happy National GDM Awareness Day, and issue which you'll have to bear with me, or maybe I'll be taking it from home. Then you may need to shift my lecture little later. What do you want to do? Am I audible, everyone? Should I continue?
Sir,
Yes,
you are audible, sir.
You are audible.
Okay, Kavita madam, then I'll continue. I'm sorry. Huh?
Sure, sure.
Okay, so my today's talk is on preconceptional evaluation, counseling for women with diabetes, and window of opportunity, and that's what we call it as a fitness for pregnancy. And I'm thankful to DIPSI, the Diabetes Care Foundation of India, PSG, IPN, and the Metabolic Syndrome Disease, or all these organizations which are the part of this meeting. And on this National GDM Day, on behalf of DIPSI and DCFI, I'm thankful to you for this initiative, and hopefully we'll continue it every year. This is again congratulations to all of you from this. And before I forget, I would like to invite you for this the International Conference 13th Thyroiditis Academia 2026, which is scheduled on 19 to 21st of June. And in this 3 days meeting at Nagpur is going to have a Vanal RSSDI 2026, which is from in the month of November at Bengaluru. And we are as a host and scientific chair of the meeting, I would love to invite you all for this meeting. So please block your dates for Bangalore RSSDI. There is no conflict of interest for this particular session. We'll have introduction. We'll have preconception, counseling, care. What are the queries? Who you are going to be facing from women with diabetes when they come to you who are known type 1 or type 2, oral drugs, insulin therapy, and the carry home messages. Now, we as a diabetes educator and dietitian should understand that the pre-JDM is gradually on going to appear early before 24 weeks of pregnancy, and we call it as early GDM. All this GDM, when we say, it appears in pregnancy and disappears almost in 85% of the cases after delivery. 15% of them, they may remain hyperglycemic, and they may need treatment even after delivery. But when you talk about pre-GDM, it is also being called as DIP, diabetes in pregnancy, by one of the classification from FIGO. So they are known type 1 or type 2 diabetes, And when they are planning for pregnancy, that is what is utmost important, called as preconception counseling and care. So pre-GDM is on rise. Why? The number of type 2 diabetes women of childbearing age are increasing. The trends of obesity and physical inactivity in this group, young girls group, is increasing. Women continue to delay their childbirth until their late 20s or even beyond. If you see most of the, even our own data of around 1000 or 1100 pregnancies of GDM, the average age of these GDM women is 29 years. And those days when I was born, my mummy possibly was even underage. And many of us who have been born 30 years back, 25 years back, even their mothers were in early 20s, 22, 23, 25. But nowadays, because of this transition phase of our culture, which has, there's so much of change in our thought process amongst the young generation, that they don't want to become pregnant, or they don't want to get conceived in late marriage, late childbearing age, and that is causing another problem. So the age of diabetes, marriage and the pregnancy is going up, and that is why you are going to have a mismatch. Up till now, last 2 decades or 1 decade ago, there are very few number of pregnancies who have been coming to you with pre-gestational diabetes. But nowadays, you'll find in your OPDs, you'll find more and more number of known type 1 type 1 diabetes. So there are people coming
Sunil sir, we
clinician to
are able
understand the
to
risk
hear you
associated with
properly.
known diabetes. You able to hear us properly, right?
There have been, times where your voice is crackling a lot and the continuity does not go on. Is it just me or somebody else also feels that? Lata ma'am?
Yeah,
Sunil sir,
we
can you please
lost
continue
I think
talking?
he lost the
Because
signal.
now it seems
Yeah,
it's
now
okay.
it is okay. I think if sir keeps his video off now, I think
Yeah.
it will be better. He'll get a better bandwidth.
Yes, I
His
have kept
video
my
is off
video off
only,
now.
Cheryl.
Yeah,
Yeah, his
नहीं नहीं
video is
अभी
off
अभी
only.
अभी
it's
किया है
better.
मैंने
Now it is
ध्रुव के
better.
अभी किया है बेटा मैंने अभी किया है
हाँ जी, हाँ जी.
Fit
Okay.
है, sir.
ठीक है. So we have to describe now. We as a clinician and educator need to know now, how do you describe an ideal candidate for pregnancy when you have known type 1 or type 2 diabetes. And we also have to understand the treatment strategies to improve the neonatal outcome, which is the aim for such pregnancies. Now, one should know that if you are known type 1 diabetes or type 2 diabetes, there's definite genetic risk to the next generation. That's utmost important. But important more than that is there's an increased maternal pre-gravida weight and decreased pre-gravida insulin sensitivity, which strongly correlate with the neonatal growth, especially the fat mass at the time of birth. So if you have if you have adult women who is with obesity, and if they becoming pregnant, there will be fetal neonatal overweight, and this neonatal overweight will be delivering a baby with who might be
Sir, again network glitch.
sensitivity, and will become another obese adult in future. So this vicious has to be taken care. So gestational diabetes is a harbinger of vicious cycle of this. Okay, so I feel I will not say anything now. Continue with other speakers. I will take another half an hour, go to other location for my connectivity, and then I'll start my session.
Okay, sir. I think that's better, sir. Because it's such an important topic. We really don't want to lose this.
Give me 20-25 minutes time.
Sure,
I'll
sir.
go to
We'll
different.
start with the case and we'll do the first case at least. We'll start with it.
Okay, okay, fine.
Yeah.
So by the time Sir joins us back again, because this is such an important topic and basically this is setting the note of the day. So let us begin with the next case discussion that would be taken care of by again two of the stalwarts who have been working in this field. And Dr. Shalini Jaggi, I welcome you, Dr. Shalini, who is the consultant and director, Life Care Diabetes Center, New Delhi. She is fellow of Royal Colleges of Physicians of London, Edinburgh, and Glasgow, and a fellow of American College of Endocrinology, USA. She is also national president of DIPSI and chairman RSSDA Delhi chapter. She has been serving as advisory board member, APAC Committee 2024 and 26, and Belonging Leadership, Opportunity Outreach and Mentorship Committee 2026. She has been chairing diabetes
Ma'am,
and
that's
mental.
okay. I think we can go on.
Okay. And also for this case-based discussion, we also have Dr. Lata Shashi, who will be talking from the nutritionist perspective. Dr. Lata is PhD in Food and Nutrition and Chief Program Officer, Core Group for Fertility and Maternal Nutrition, IAPN India. Currently, she is with us. She is working as Chief Nutritionist and Head Department of Clinical Nutrition and Dietetics, and she is associated with Fernandez Hospital, Hyderabad, and having a rich experience of more than 25 years of clinical practice, and areas of specialization includes maternal and child nutrition, gestational diabetes, and nutrition in high-risk pregnancy and multipetal pregnancies and whatnot. So many awards like Young Scientist Award of Nutrition Society of India, NSI 1997, and R&D Sadhana Award 2020, International Congress of Dietetics, so many. I mean, the list is endless, and so as her publications. So without wasting much time, over to you, Dr. Shalini and Dr. Lata, for the case-based discussion. We are eagerly waiting to hear both the perspective, both from the clinical and from the nutritionist view. Over to you.
So, good evening, everyone, and thank you very much, ma'am, for that warm introduction. And thank you, Kavita, ma'am, Cheryl, and IAPN for this opportunity, because GDM, hyperglycemia in pregnancy, is something which is very close to our hearts. And I think today is the apt day, the best day to have this kind of a webinar when we're celebrating, the National GDM Day with Dr. Professor Sesha's birthday. So, the case that we are going to discuss is something that we see very often in our clinical practice. And so what we'll do is we'll quickly present the case. Let me just share my... so will someone be sharing it, or should I share it from my side?
You share it from your side.
Okay, just give me a minute.
While we share the screen, a very good evening to each one of you. It's definitely a privilege that we have here to amongst all our stalwarts in the field of endocrinology to join us and share the screen, share the webinar to share our inputs. So we are taking this first case forward as a duologue so that we are taking this over. Over to you, Dr. Shalini.
Yeah. So thank you, Dr. Lata. So what we will be doing in the next 10-15 minutes is both Dr. Lata and I will be discussing different perspectives to this very common practice case that we are coming across now in our OPDs, and we'll take it from here as a duologue. So what we are going to discuss is PCOS, obesity, and a background of GDM, especially early GDM, which we are detecting these days. So let me introduce Mrs. Anjali to you. She's a 29-year-old architect, primey at 7 weeks gestation, and referred to our clinic by her OBG, as the DIPSI test done in the clinic when she came to her with the UPT positive showed a value of 154. So clearly something is amiss here. As all of us know, the normal DIPSI value has to be less than 140. And usually now we are saying less than 120. And we'll do this discussion in a little while. So on taking a history, this girl does not have a history of diabetes in the past. She's been married for last 3 years. But yes, she does give a history of PCOS, which was diagnosed at 15 years of age. And right since her teenage, she's been struggling with weight, gaining weight, losing weight. Prior to her wedding, she went on a massive weight loss diet, lost about, a good amount of weight, which does happen in our culture. When girls are wanting to get married, they'll go on intensive weight loss, exercise regime. And once they're married, everything goes back down the hill. So she's regained about 12 kgs in the last 3 years. Now that she's pregnant, you see this derangement in the DIPSI test. Her current BMI is almost touching 30. Very, very common that we see these days. Family history of diabetes is positive. Father has type 2 diabetes and CAD, and he's on oral drugs. So now let's first have a discussion on the diagnosis. And what would we classify this as? Is this a conventional GDM or early GDM? Or was it pre-existing diabetes that we've picked up at this point because she's obese, she's got PCOS, she's got the risk factors? Or is it diabetes in pregnancy? So
Exactly, Dr. Shalini.
Yes, ma'am.
So we usually have this big doubt, usually from this typical case like this, that they always ask us, ma'am, so I didn't have any symptoms till now.
Yes.
So that's the first thing the woman always has to ask us. And how can this be gestational diabetes? Because they have always heard that gestational diabetes is something which comes in the 24 to 28 or the 7th month. So is this the conventional GDM or is it early GDM? Over to you.
Yeah. So let me take you to this very important table, which is basically an umbrella term called hyperglycemia in pregnancy, jointly coined by WHO and FIGO, which has tried to streamline things in terms of different aspects of hyperglycemia in pregnancy based on the presentations. So on the one hand, you have pre-GDM, which is definitely pre-existing diabetes, which means women who already have type 1 diabetes or type 2 diabetes or any of the forms of diabetes prior to pregnancy. Then you have something called DIP or diabetes in pregnancy, which is pregnant women who are presenting with hyperglycemia for the first time diagnosed in pregnancy, usually in the first trimester when you do the first test, but they meet the WHO criteria of diabetes in a non-pregnant state. What does that mean? That means fasting is already more than 126 or the 2-hour postprandial is already more than 200. So clearly, this was pre-existing overt diabetes, which was missed prior to pregnancy. Maybe she had it earlier. She did not know about it. And now when in the first trimester we are testing her, we've picked it up. So this is frank dysglycemia usually. So the HbA1c, if you do as a confirmation, will usually be above 6.5%. So clearly this kind of variety is called DIP or diabetes in pregnancy, best detected in the first trimester. And the management is exactly like how you would manage somebody with type 1 or type 2 in terms of intensive basal bolus, insulin regime, and MNT and lifestyle, which we will discuss in a little while. Now, GDM typically can occur anytime during the antenatal period and is usually not expected to persist postpartum. So this is clearly new onset dysglycemia with no prior diabetes. Glucose levels are still mildly deranged most often. HbA1cs will usually be less than 6.5. So these are women who did not really have diabetes but are getting it in the pregnancy itself. Conventional GDM was something that we usually used to say happens at 24 to 28 weeks of pregnancy, which is when the diabetogenic stress of all the placental hormones comes into play, increasing the insulin resistance and thereby causing dysglycemia. So that was conventional GDM. Now what we are seeing largely in the global population, more so in the Southeast Asian countries, in our ethnicities, is eGDM or early GDM, which is GDM diagnosed at less than 20 weeks of gestation. Usually they will present, at about 8 weeks, 10 weeks, 12 weeks, 14 weeks, even 16 weeks. The degree of dysglycemia is usually milder compared to the frank diabetes levels. HbA1cs are again in the either pre-diabetic range or sometimes even less than 5.5, usually 5.3 to 5.5 also. So this is definitely GDM, but early GDM. So when we talk about this case, this girl, so like I said, if you go back to what I showed you, BMI is 29.8. She already has PCOS. She does have a positive family history of diabetes. So all the risk factors for GDM were already there. And clearly we know women with PCOS, extreme amount of insulin resistance, once they get pregnant, they've already been putting on weight. So there is chronic insulin resistance already in the background. Now, as they get pregnant, they will tip over, and that is where they will develop GDM much earlier compared to the conventional times. So this lady falls into the diagnosis of eGDM. And when we did an HbA1c for her, it was again 5.5%. So clearly telling you that this is eGDM.
Thank you, doctor. That's clear.
So now moving on. Lata ma'am,
Yeah.
this is where you also have to help us because we've
True.
diagnosed EGDM. We
Yes.
will be asking her to go for intensive SMBG, lifestyle, diet, and we'll discuss pharmacotherapy in a little while. So now, when we send this patient to you, because nutrition has a huge role to play in managing, a hyperglycemia in pregnancy or gestational diabetes, what would be your advice?
Great. So this case specifically, as your case rightly said, the woman has already gone through the ups and downs of her weight. So the first thing that always strikes them is, should I lose weight because I'm being told that I'm an early GDM? So the first guidance that we need to give them, there is no weight loss recommended during pregnancy. So we start with telling her that what changes your diet or your diet advice now would be to just look at moving your diet to eating to appetite with the target of choosing complex carbs over simple carbs. So, what she needs to avoid would be the simple carbs. So, all high fat, high salt, and high sugar. So, anything simple carbs from point of sugar, honey, jaggery, all needs to go. And that's what only needs to be avoided. But all other complex carbs coming from whole grains, the vegetables, and a meal that we always talk of low glycemic index should continue. Another thing very important is there is definitely no extra recommendation for additional calories in the first trimester. So, just because they have tested positive, UPT positive, there's no reason for them to increase their calorie intake during this phase. And as per the Institute of Medicine's weight gain guidelines, also, there is no additional recommendation for weight gain in the first trimester. So, the calorie intake for this woman would be continuing to be at what she is right now eating with a target of ideally no weight gain or a weight gain of up to 1 kg in the entire first trimester of the first 3 months. She would need to add additional fiber in the form of whole vegetable salads. She would be actually wanting to add in additional protein sources at each meal so that that makes it definitely a low glycemic index diet, and need to concentrate on her folate content in her drink. So the most important nutrient that we all need to concentrate in the first trimester is her folic acid rich foods, which definitely includes her green leafy vegetables coming in, which additionally definitely gives her a fiber too. She can take her green leafy vegetables either in a powder form, the chutney or the purees, or as a sabji with her dal. Also, nausea and vomiting is one of the common written that she might face in this trimester. So, even for that, we would please advise her she would not need to shift or avoid a meal, but let her take her meals in the 3 meals and a snack, but always concentrate on alternating a wet and dry food. So, when she's nauseated, she could eat something dry and take a fluid later. So, in that way, she could still continue her diet as she was taking in pre pregnancy, but her target should be to eat to appetite and have a balanced meal. She would continue to take complex carbs, good quality proteins, and amount of fats that basically goes into 4 to 5 teaspoons of visible fat, which we say is 4 to 5 teaspoons of oil per day. Definitely needs to be physically active too. Recommendation would be up to half an hour of walking. Again, split up if she is comfortable. 10 minutes 3 times a day or 15 minutes twice would definitely support her for this too.
Absolutely. I think this is very important. You know, small, frequent meals, more of proteins,
Protein,
less of carbs, more of fibers, nuts. I think
nuts.
so. Healthy nutrition does not mean, many a times we see females who get very scared when you tell them, you need to
True.
control and they'll stop eating. Either they'll completely stop eating, to the risk of, getting into IUGR, malnourishment. And
Exactly.
on the other hand, you will have people who overdo things.
Things. True.
So a balance has to be maintained. And when it comes to exercise, again, if they can do a half an hour 45 minutes walk,
More
perfectly
than it.
fine. If
True.
that is still not possible, just a small 15 minutes walk after every meal does help a lot.
True.
So For females where walking is contraindicated sometimes, they'll have a low-lying placenta previa, those kind of things. So there we tell them to do upper body exercises. So,
Sure.
any form of exercise is better than no exercise. I
True.
think that should be the message.
True.
Swimming also they can do. Only thing is high impact exercises like skipping and jumping is something that we tell them not to do.
Not to do.
Otherwise, and again, another very important point is for somebody who's been sedentary all along.
True.
Suddenly telling her to walk 45 minutes when she's pregnant can sometimes be very detrimental.
True.
So we tell them to start slow, and then slowly, as they become comfortable with that particular mode of exercise, then probably they can intensify their exercise. That's
Yeah.
very important.
Sure.
Moving on to self-monitoring of blood glucose. So the targets definitely for all pregnant females, irrespective of whether it is type 1 or type 2 or GDM, pre-GDM, very clearly fasting glucose has to be between 70 to 90, definitely not exceeding 95. That's very
Okay.
important.
Okay.
Similarly, to our post-meal value, it could be a post-breakfast or a post-lunch or a post-dinner, has to be between 100 to 120, definitely not crossing 120.
120. Okay.
Why these cutoffs exist is because we know that as the glucose levels go beyond 120, beyond 140, they'll cross into the placenta. Fetal hyperinsulinemia can begin and the child becomes macrosomic and they are at a risk of getting polyhydramnios and all that.
True.
Why we need tight glycemic control in early pregnancy, especially in the first trimester? Obviously, we know a very high risk of congenital anomalies if the glucose levels are not on target. So
Right.
that is why first trimester, a high risk of congenital anomalies, neural tube defects, cardiac defects, anencephaly, microcephaly, all of them are there. That is why you give them folic acid preconception or immediately as they conceive. Folic acid has to be part and parcel to prevent neural tube defects. And then second trimester and third trimester, because the set of complications again changes if the glucose levels are not controlled.
True.
So moving on from here, we've managed her with MNT, we're managing her with
I have a question, Dr.
pharmacotherapy.
Shalini. What is the frequency of doing SMBG? I mean, is
Okay.
it daily or weekly?
Yes. So if this is somebody who is well controlled with diet, who's not really on any major insulin doses, or even she's controlled well with metformin. Now we'll have a discussion on metformin eventually.
Yes, I have a question.
So if she is controlled with MNT lifestyle, you can be a little less intensive in terms of doing a fasting and a postprandial once and maybe a post lunch and a post dinner on another day. But
Right.
somebody who is on intensive insulin therapy,
Okay.
or somebody who is a high risk patient, there ideally 7-point SMBG is recommended, which means fasting, post breakfast, pre lunch, post lunch, pre dinner, post dinner, and even a 3 a.m. at times.
Oh, okay.
However, doing 7 SMBGs can sometimes be very cumbersome. So in our clinical practice, we tell them to do at least a fasting and 2-hour post meal so that they can adjust their insulin doses as well.
Sure.
However, these days in pregnancy, we are using continuous glucose monitoring, the sensors, which have made life much easier, especially for patients on intensive insulin. So if she can afford it and she's able to do CGM, nothing like it. However, at least a 4-point SMBG if she can't do a 7-point. That is indicated.
Daily or twice a week would do, doctor?
That's what I said. So if it is just a GDM managed on MNT lifestyle, maybe twice a week or thrice a week, depending on whatever she's comfortable with, she can do it.
Sure.
However, if she is on insulin, it has to be daily, at least 4-point SMBG.
Got it. Right. Yeah. So then we go on to, as you said, the pharmacotherapy now?
Yes. So pharmacotherapy, now again, there's always a debate between insulin and metformin. So let me put it forward that insulin definitely remains the drug of choice, the gold standard for any management of hyperglycemia in pregnancy. But of course, since it is, because we know insulin does not cross placenta, so there is absolutely zero risk of fetal harm.
Right.
But however, mild dysglycemia or, somebody who's not willing for insulin, you can give her a trial of metformin, because earlier we had a lot of issues with metformin, but the government of India, DCGI, has now given approval for use of metformin in pregnancy,
Right.
especially women with PCOS who already have insulin resistance. Usually they will already be on metformin preconception for their insulin resistance or weight management. So they can be continued on metformin. However, certain conditions, contraindications to metformin would probably be number one, GI intolerance. A lot of them get acidity, gastritis, loose motions, constipation. So,
Yeah.
if she's not able to tolerate metformin, you have to stop it. Or, if she's not gaining weight, or if she's losing weight during pregnancy,
Right.
IUGR, risk of small for gestational age, you need to stop. Again, if she's developing hypertension, preeclampsia, we do have a case discussion on preeclampsia where I think Dr. Rutul is going to talk about metformin again. So, unless until it is not tolerated or there are contraindications, you should not use metformin. Otherwise, you can give her a trial of metformin.
Okay.
However, if the glucose levels are not on target, she has to be on insulin, and insulin regimes, I think Dr. Rutul would be taking it forward during the discussion. So usually in pregnancy, if it is conventional GDM, it is the post meals which are high. The fastings will still be normal.
Normal.
So
Okay.
that is where you just need a prandial insulin before the meal.
Right.
However, if the fasting glucose is also going up beyond 95, that is when you need to add a basal insulin, which could be, either detamir is being phased out now. So basal, you can have degludec insulin or even glargine. Now, if the lady is already taking glargine is already safe. And Rutul and I, we did publish a paper on glargine use in pregnancy. So glargine can also be used. And then rapid acting boluses could be any of these insulins, which could be conventional insulins like Aspart or fast acting Aspart, or even Lispro insulin, or the usual regular insulins can be given.
Oh, great. Thank you. So metformin can be given, especially
Yes.
in this case, because she's already had a
She's
history of
already PCOS, she's obese, so metformin can be given. However, if the glucose levels are not on target, definitely, and since we are picking her up very early,
early.
this is a stage where the risk of congenital anomalies is very high. So maybe starting insulin could be a good choice. You can ask her to do intensive self monitoring for the
Right.
first few days to see if she's managed well.
Well,
However, if the glucose levels are exceeding, we don't want to wait for 2 weeks, because you'll miss the entire window for congenital anomalies. So maybe starting insulin could also be a good option here right in the beginning to prevent congenital anomalies and to intensify glycemic control as early as possible.
yes. Thank you, doctor. So the key that for such a case, when we catch them early, we are able to really. So we need to stress the entire team of dietitians and the obstetricians and endocrinologists always need to emphasize on the need for strict glycemic control with whatever parameters. It cannot be that it's only a 1 point that is away.
Yes.
So my HbA1c was okay is usually again a challenge. So we need to be very clear when they have a higher risk with all others. A tighter glycemic control, as doctor just explained, is definitely needed so that we are avoiding all the various congenital malformations, all other problems that
Yes.
the fetus can also have.
That is why, sorry, I'm so sorry to interrupt. Conventional GDM, we say give her a trial of metformin, MNT,
Okay.
lifestyle for 2 weeks, and then you start insulin if she's not on target. But here, this is very early pregnancy. She's just 7 weeks.
So that's the
The
difference.
neural tube starts getting formed at 3 weeks. 18
True.
weeks post fertilization, you have the neural tube coming in.
True.
The heartbeat comes by 6 to 8 weeks.
True.
So you cannot afford to have dysglycemia at this point,
At this point.
because the risk of congenital anomalies can be high. So that is why you need to be a little more intensive when you have EGDM.
Exactly. So every dietitian and nutritionist would like to make this point very clear. We are discussing an early GDM case, which is definitely slightly different from the conventional GDM, and the need, as Dr. rightly very beautifully explained, why we need to stress on it. And as we do this, we also need to concentrate on explaining to the mother that she has to be conscious of her weight gain. Not that we are asking her to lose weight, but her entire pregnancy, her weight gain should be within 5 to 9 kgs as she started with a high BMI. So this
Yes.
helps us managing her glycemia very well. If she in the first trimester she's in control, and then second trimester we give her at the rate of 1 kg per month and then move on. So weight gain also has to be in strict control. Great. Thank you, Doctor.
Absolutely. And
Yeah.
one thing you need to stress, pregnancy is not the time for weight
Weight
loss.
loss. Exactly. We
So,
don't.
so you need to tell them, prime them, sensitize them, because this is a low hanging fruit. They are very open to what you're telling them. So maybe
True.
prime them, that postpartum, there'll be a discussion on postpartum. They need to focus on metabolic health. They need to focus on losing weight. The gestational weight gain has to be
Weight.
minimum.
True.
So those things. But yes, during pregnancy, I think tight glycemic control, tightrope walk is very, very important at this point.
Exactly. Thank you so much, Doctor. So I
Thank you.
think we should end here for the next case to take on.
Yes. Yes. Thank you,
Sure.
ma'am.
Right. Thank you.
Thank you so much, Dr. Shalini and Dr. Lata. Like, what a brilliant discussion. We all were completely hooked to our screen, not being able to move as well. Every piece of information and advice that you have shared was genuinely, like, these are the recent trends that has to be followed. Because if we really look into the history, GDM has a very long history. Like, initially recognized in the early 19th century as a very dangerous, often fatal
True.
complication of a pregnancy at that point of time. And before the discovery of insulin and the modern obstetric care, the condition was characterized as extremely, like, it was characterized by extremely high rates of both maternal and fetal mortality, often
True.
exceeding 50%. And now today, the way we have controlled it, because of the immense contributions that has been done since 1824 by the German physician Hendrik, then J. Matthews, and the day that we are celebrating today, as Dr. Shalini has already mentioned, because of the birthday of Professor V. Sheshia, like, was born on March 10th, and that is the reason the GDM awareness is being celebrated this day, because of his immense contribution in this particular field. And it is the contribution of the researchers and the contribution of you all who have been working extensively in this field, which could actually drop down the consequences of the gestational diabetes. And like, really, the people can now, even if they are getting dysglycemic, we know, like, the doctors are also having an idea that what can be done, like, what are the pre, what are the post, how the things are to be managed. So that fear thing has gone now. The
True.
previously with fear, lot of thing was there, so that fear thing is gone. So it was an
Wow.
excellent discussion on the interplay of the PCOS, obesity, and EGDM. And before I talk too much, I will quickly take up a couple of questions if it is there.
We'll have to ask RX to share if there is any questions. Please do share. But I think in the meantime, we can start with
Start
sirs.
with sirs. True. True.
Yes.
Thank you.
Thank you so much.
Thank you,
Sir,
everyone.
have you joined?
Sir is joined. Sir is joined.
Okay. So, sir, we are eagerly waiting for your session. So you may please start, sir. The fitness
Okay.
for pregnancy. So that is the main thing that we all should be knowing. Thank you, sir. Over to you.
Yeah, thank you once again. I feel you already have thanks the organizers and all other these slides have been done. So I'll start from here. So it's an utmost important situation we all are going to face in future. As I told you that the age of marriage is going up, age of pregnancy is going up, and age of type 2 diabetes is coming down. And more and more young people, almost 30% of your people with type 2 diabetes are being diagnosed now below 30 or 35 years of age. And these are the days where you are going to these women are going to plan their pregnancy. So more and more number of pre-gestational diabetes you are going to face. More importantly is, if you just go through the ICMR data which got published in June 2023, which says that almost 13.6 million people, 13.6 crore people, they are above 18 years of age, they have they have pre-diabetes, and almost 10.1 crore people above 18 years of age, they have diabetes. That means almost 23.7 crore people, almost 24 crore people out of 94 crore adults above 18 years of age have some kind of dysglycemia. And if you just try to recollect your older definition of GDM is IGT in non-pregnant state is GDM in pregnancy. So all these women who are going to be pre-diabetes actually are going to have GDM, and that's why it's not only every sixth but every fourth woman in India during pregnancy might be having some kind of hyperglycemia in pregnancy. 85% of them might be the GDM, which appears in pregnancy, disappears after delivery, but almost 15% of them might be pre-gestational type 1 or type 2 diabetes, and few of them would not have been diagnosed, have been diagnosed only, are usually being diagnosed during the screening of pregnancy investigations. So it is utmost important to understand the risk associated with diabetes, though pre-existing diabetes. How does the diabetes affects pregnancy? How does pregnancy affects diabetes? Who are the ideal candidates for pregnancy if they have known diabetes? And also to understand what are the treatment strategies which will certainly give you or ensure you the best neonatal outcome. That's what the aim of the treatment of pregnancy. And this slide I already told you, we have to check this this vicious cycle, which is utmost important, that you have the women with gestational diabetes giving a baby who has been exposed to intrauterine hyperglycemic environment, and this intrauterine hyperglycemic environment is likely to have its impact on the एक second, I'm trying to use the marker. If I can, I don't know, I can drag it, or I don't know. So so this vicious cycle, so you'll have a baby who has been born with obesity or macrosomia, epigenetic risk, genetic risk already there. And if this is an opportunity where you can, if you act somewhere here is at most important. If you treat the hyperglycemic women aggressively, intensely, to the extent that baby doesn't recognize that the mother has diabetes, could be the first step towards prevention. And then, of course, these women, if these is female, obese women, macrosomic baby becoming women, obese women becoming diabetic, having polycystic ovarian disease, and again becoming pregnant. So this vicious cycle of obesity and GDM need to be taken aggressively managed. There are various mechanisms. I'll not go in detail of it because we are all educators, and diabetes educators are expected to do something very, very important in counseling. I feel I'll be focusing more on those lines. Now, this is an important slide. When baby is exposed to the hyperglycemia in the first trimester, first 6 to 8 weeks of pregnancy is a period which is a period of organogenesis, which get extended to almost 10 weeks. So up to 10 weeks of pregnancy, you are likely to have the एक second, I line no shape will just I'm just trying to use this marker, which I am unable to do that. I don't know how it is being done. Something wrong here. So 8 to 10 weeks a period of organogenesis. So if your baby is getting exposed to hyperglycemia in the first trimester, they are likely to have a high risk of teratogenicity because there's a period of organogenesis. If the hyperglycemia is coming after 10 or 12 weeks, or maybe the second trimester, then it is mainly the beta cell development and the islet cell development which might get affected. And of course, the third trimester hyperglycemia, which is usually seen in GDM, is causing basically macrosomia and high birth weight babies. So every moment you need to have the control. Now let's come back to the pre-existing diabetes, type 1 or type 2. Now you are planning, you are an educator, and you are now planning to educate a person, women coming to you with the desire that she is known type 1, she is known type 2, now she want to get conceived. So what are the issues which are going to be coming in front of you? Any woman with reproductive age, I repeat, any woman of reproductive age who is not actively using reliable contraception may become pregnant. The periconceptional glycemic control is single and most influential factor in the embryonic development. It's not the blood glucose when you diagnose the pregnancy is only important. It is also important that the baby, when there is the conception, from the day one of conception, the periconception glycemic control is more important, and which will be more correlated with the neonatal outcome than the HbA1c or the glycemic control at the time of diagnosis of pregnancy. So organogenesis occurs before the pregnancy gets recognized. साहब गलती से हो गया, and this risk reduction is most effective before conception. So you have to control it much before the woman gets conceived, weight loss pre-pregnancy improves the ovulation, metabolic profile, and pregnancy outcome. So if you have some obese women, which is very common nowadays, almost 30% of the young ladies coming to pregnancy might be having either overweight or obesity, and this is going the higher weight is going to have its impact on the ovulation, metabolic profile, as well as pregnancy outcome. So you have to have a preconception counseling, should be ideally starting at puberty. All women, people with diabetes, especially children with type 1 diabetes, should be starting their education from puberty, and as well as those who are childbearing age. Effective contraception should be told to them so that they should not come out with the accidental pregnancy. Try to achieve HbA1c target of less than 6.5. I'm still trying. Yeah, now I will be able to do this. Yes, now I'll be able to do it. So 6.5 less. And with a history of GDM, those who already have history of GDM should seek preconception counseling again, because they're going to have developed diabetes again in the next pregnancy. Now, this is important slide. If you are getting pregnant less than 20 years of age, almost 82% of these, this will be accidental pregnancy, unplanned pregnancy. Once you are little mature, 20-25, almost 60%. And 20, once you are more than that, 25 years, more than around 30 years of age, then almost 41% of them, they are unplanned pregnancy. And this is a data, even women with diabetes, true. Only 26% of the women, they are planning pregnancy properly. Rest of the almost 75% of the women, they come to with unplanned pregnancy. So what do you mean by this fitness for pregnancy, and how do we go ahead with this? So you have to have, these are the agendas. You have to have the obstetric evaluation done by the gynecologist. You have intensive education for the patient and the partner, optimum diabetes control before they get conceived, and timing and the planning of pregnancy all has to be a part of your pre-conception counseling goals. Major congenital abnormalities in type 1 diabetes almost 10 times higher if they do not get registered in the preconception person. So unplanned pregnancy may have early growth delay, may have high risk of congenital malformation and spontaneous abortion, and this is commonly being seen. HbA1c should be kept less than 6.5, which will give almost a good minimum. Ideally 6, less than 6.5 is acceptable. In those type 1 diabetes who have hypoglycemia unawareness, or those with more high risk of recurrent hypoglycemia, up to 7 is acceptable for preconception care. If you're now, this is a question we are going to face. Someone coming to 10 or more than 10 HbA1c, the risk of congenital malformation almost 25%. Someone coming to less than 8, it is around 5%. Someone coming to less than 6.5, almost as that of the non-diabetic population. And there is also increased risk of sudden unexplained IUD, intrauterine death, in these women. If you have, apart from congenital malformation, they may have perinatal mortality as well as sudden unexplained death. So 10 questions now. These are at most important. Everyone should take, you can take a picture of this, because these are the questions and your answer, you are supposed to know the answer as educator. So I'm not going to talk on these case-based things. This is just old slide. So 10 questions. First question, does diabetic impact the woman's ability to get conceived? So if I have type 1 or type 2 diabetes, will I be able to get conceived? Most of them, almost 90% of them will be able to get conceived, but they may have delayed menarche, early menopause, delayed ovulation, longer duration of diabetes, later onset of menarche. Almost 20% of them, they fail to conceive within 2 years of attempts, and earlier onset diabetes, higher daily doses of insulin. So these are important key points answering the question of a woman. Second question she is going to ask you, I have got diabetes. What is the risk of diabetes to the infant of a diabetic mother? How much is the risk to my baby? I have got type 1 diabetes. How much is risk to my next generation, my baby? I have type 1 diabetes. So if she has type 1 diabetes, and if the type 1 diabetes has developed after 25 years of age, then the chance of developing diabetes to this generation, the type 1 diabetes to the baby, is only 1%. And if she is less than 25 years, it is 4%. But if the both parents have type 1 diabetes, the risk is not known, but it could be higher. If the offspring of mother with type 2 diabetes develop diabetes, then the risk is double as that of the general population. So general population, say, risk now at this moment of time is around 14% or 15%. or 12%. The risk to these children will be almost 24%. So double the risk of type 2 diabetes to the babies born to type 2 diabetes mothers. Third question, what is the risk of spontaneous abortion? Type 1 diabetes almost 17.5% higher, 17.5% versus 10 to 12% others. Positive association with the poor glycemic control at the first trimester, and spontaneous abortion was related to glycemic control, as I told you, at the time of conception rather than at the time of diagnosis of pregnancy. And it is the toxic milieu in which the embryo is developing is the causative factor of result into the degeneration of the embryo, abnormal placentation, abnormal vascularization, and perhaps the increased risk of chromosomal abnormalities. This is because of the hyperglycemia in women. Do the infant of mother is likely to develop congenital malformation? So the risk of congenital malformation here is almost 50% of the perinatal death of congenital malformation account for almost 50% of the perinatal death in diabetic mothers, versus 20 to 30% in non-diabetic mothers. And the risk is because of the fasting hyperglycemia in the first higher first trimester HbA1c, as well as and if you have associated vasculopathy. And now this is another kind of misconcept or misbelief that if you have type 2 diabetes, the complications are going to be less. If you have type 2 diabetes, type 1 diabetes, complications are going to be more. It is not being proved. This is a wonderful data says in a meta-analysis compared type 1 and type 2, found that type 2 diabetes women had lower HbA1c at the first weight, but a higher rate of perinatal mortality. So women with type 2 diabetes had no better perinatal outcome versus those of type 1 diabetes. And this is a diagram which will give a threshold, mean blood glucose threshold, causing various complications, stillbirth, macrosomia, preeclampsia, early demise of the fetus and everything. And this is a macrosomic baby, which is a heavyweight baby of more than 3.5 in Indian definition and 4 kg for the Western population. And these are the heavyweight baby, though they look chubby, but then they have a bad future. And then you can have a caudal regression syndrome, which is a abnormal development of the lower spine. And you can appreciate in this X-ray there is no development of the spine here. And this is typical for the it is specific for diabetes. Now, the fifth question is, if suppose someone has already diabetic retinopathy, will it cause any deterioration? So rapid normalization of blood glucose can cause acute progression to retinopathy and may cause deterioration in diabetic retinopathy. Recent data says that there may not, earlier data was saying that you may not develop the retinopathy, but recent data says there can be even development of retinopathy, and that is why we should be monitoring retina regularly. Next very important thing, if someone has retinopathy, at the time of delivery, the abrupt increase in the blood pressure that occurs in the maternal expulsive efforts during delivery may cause acute retinal hemorrhage. And that is why instead of going for the normal delivery, most of these women are posted for the cesarean section. Otherwise, the pre-proliferated diabetic retinopathy may be dangerous in such situation. If you have nephropathy, it is associated with hypertension, preeclampsia, and almost preeclampsia develops in almost 50% of the women who have nephropathy. And there is increased risk of IUGR in almost 20% of these pregnancy. What about neuropathy? Again, there's no pregnancy does not alter the natural course of diabetic neuropathy. But if you have diabetic autonomic neuropathy, which is one of the contraindication for pregnancy. How does hypertension affects? Hypertension should be aggressively controlled. Target should be less than 130/80. And these drugs are contraindicated. I feel doctors are supposed to know this. Preferred medication will be methyl-dopa and others. I feel you have some case where you are going to discuss this. Should women with diabetes expect an increased incidence of obstetric complication? Yes, preeclampsia, acute hypertensive complications, and will have more common if you have microangiopathy. And each increment, important, each increase in 1% of HbA1c during pregnancy conveyed a 37% increased risk of preterm delivery. Last question is, what are the risks of associated with coronary artery disease? So if you already have coronary artery disease, women with pre-existing coronary artery disease, pregnancy and delivery can result in inadequate myocardial oxygenation, leading to myocardial infarction and heart failure. And absolute or relative decrease in the ability of the coronary blood flow to meet the demand of the myocardium. And that's why myocardium damage and pulmonary edema is common. And in such patient, after vaginal delivery, there is an immediate 60 to 80% increased risk of increase in the cardiac output, which could be dangerous. And that is why Caesar is being preferred. What about statin? Again, those who have familial dyslipidemia, it is allowed, but otherwise it is contraindicated. Aspirin is low dose aspirin has to be given starting from 12 to 16 weeks onwards to prevent the risk of preeclampsia around 100 to 150 milligram. Preconception vitamins, so folic acid and maybe has been given. And the 150 milligram potassium iodide is recommended. Smoking and tobacco is contraindicated. And there are now few women, because now we are more talking about obesity, and you as a nutritionist are going to face more and more women who are being given the GLP-1 analog or the GLP and GIP analog twin incretins have been given to patients. Let's maybe semaglutide, could be tirzepatide. And these women are obese women and they're planning for pregnancy. Now the infertility clinicians, they are asking them to reduce weight so as to have a better neonatal outcome. Now they have come to you who's already on GLP-1 analog, and accidentally if they get conceived, what is going to happen to these babies? So we don't have a dedicated trial of GLP-1 analog in pregnancy, but these are the data. Their pregnancy, around 938 pregnancies have been exposed to semaglutide, especially semaglutide here, GLP-1 analog, or liraglutide, and they're different GLP-1 analog, and they have not shown any much of the concern. There's no data on the maternal glucose outcome, no data on stillbirth or abortion, and there is no increased risk as per this data, observational data is concerned. But altogether, if you take the messages, there is no studies examining the periconceptual use of GLP-1 in this, and the data on teratogenicity is neither proven nor disproven. So at this moment of time, it is contraindicated, and we should withdraw. If you are using semaglutide, you have to withdraw 2 months prior, and if you are using tirzepatide, you have to withdraw 1 month prior to the conception. So when you're planning fertility, if you're attending fertility clinic, planning the IVF, in such situation, you have to have the 6 to 8 weeks for 8 weeks for semaglutide and 4 weeks for tirzepatide. So I'm just skipping these slides for the want of time, tirzepatide and all that. So preconception use of incretin-based therapy, significant weight reduction may improve the metabolic health in these women, and the fertility outcome may improve. But the data, unfortunately, we don't have data on the fetal exposure, unplanned pregnancy, weight regain after. So once you withdraw it, say 2 months you have withdrawn semaglutide, then in these 2 months, there can be little weight gain. During the pregnancy, again, we are not sure how many of them will continue to gain weight. And excess gestational weight gain is another possibility. And last but not the least is nutrition deficiency, because we're going to have some muscle loss and some nutrition deficiencies. What are the complications? Maternal complication, increased insulin requirement, hypoglycemia, ketosis, deterioration of retinopathy, proteinuria, edema, miscarriages, preeclampsia, the maternal complication of pre-existing diabetes, congenital malformation, spontaneous abortion, macrosomia, polyhydramnias, neonatal hypoglycemia, IUGR. These are common complications of such pregnancies. Ketoacidosis. If some type 1 diabetes develops ketoacidosis during pregnancy, the risk of fetal death is more than 50%. And we have phase 2, one survived, one we lost. So important, you have to treat the mother and save the mother here. What are targets? I feel we have already seen, so I'm not going to go in detail of it. Target, of course, you have to have, if you're type 1 diabetes, now you have CGM data also available. So type 2 diabetes, you try to keep the CGM data between 63 to 140, and TIR in type 2 diabetes and GDM should be kept of more than 90%, while those who are type 1 diabetes, 70% TIR is being recommended. Insulin is the drug of choice in type 2 diabetes. Type 1, of course, only insulin. Type 1 diabetes, insulin is a drug of choice. Metformin, glyburide should not be used as a first-line therapy in these individuals. I feel this is the possibly last few slides, 2-3 slides, who is the ideal candidate for pregnancy. Now I'm going to fitness for pregnancy. Who has well-controlled diabetes, not much of the glycemic variability, normal HbA1c, absence of vasculopathy, preconception folic acid, normal renal function, ability and willingness to monitor blood glucose at least 6 to 8 times per day. What are contraindication for pregnancy? Well-established ischemic heart disease, active proliferative diabetic retinopathy untreated, renal insufficiency, severe autonomic gastroparesis. These are the contraindication for pregnancy. So final message is young diabetic women aspiring for pregnancy is on rise. Every woman of childbearing age is potential candidate. Most of the women with diabetes can get conceived. Dedication for monitoring. Glycemic control is must. Follow the preconception counseling protocol called meticulously. Screening for micro and macroangiopathy before conception increases the safety. Indication and contraindication pregnancy need to be emphasized. But don't forget this statement, 90% of the diagnosed pregnancies are accidental pregnancies, and we should be prepared to face this challenge. Galti se ho gaya. This sentence is one of the most irritating sentence I get, but I can't express it on my face when I face a patient. And this is my last slide, which I love, almost showing it since 25 years, 30 years. If the glycemic control can be maximized to the extent that the fetus no longer recognizes that the mother is diabetes, then the treatment of mother during pregnancy may become the first step in prevention of obesity and diabetes in the offspring. So from the day of conception, from the periconceptional period, during pregnancy, till the baby is out, your blood glucose should be strictly controlled, strictly managed, and then you can have a best outcome in this fetus. So focus on the fetus for the future is a theme. And now today is a National GDM Day, 10th of March, birthday of our beloved professor and founder of DIPSI, Dr. Seshaya sir, who is Padma Shri. And we should do this education program more often, and not only on the National GDM Day. And my pranam to Professor Shaya. And we are doing this Prega Talk, which is a public awareness program, and many of you have been the part of in different languages. And so now India has a 22 languages in the Constitution of India, and we have conducted the first cycle, second cycle, third cycle, and on this Sunday, on 8th of March, we have again launched the fourth cycle of Prega Talk. And this time, apart from the all 22 languages in Indian Constitution, we have the languages of other South Asian countries. We already completed Nepali. We have completed Sri Lankan language, Sihasi, and now we will be going ahead with Bangladeshi and other language in near future with the idea of Southeast Asia. Thank you very much, Dr. Bansi Sabu, who has been instrumental in getting a collaboration with the DIPSI and Hello Diabetes with the Prega Talk program with IDF. So with this, I stop here, and I hand over this mic back to our conveners and the moderator. Thank you very much, everyone, for patience listening. If you have any question, I'll be more than happy to answer that.
Thank you so much, sir, for this beautiful presentation, beautiful evidence-based, like every step there was a research, and the way you have set the note for the day, like they set the theme. I mean, you started with the preconception, like how they has to be done, then answering those 10 questions. Yes, it is very important कि गलती से ना हो जाए. So very well put, sir, very well put, because as the children are the future of our nation, so it is our duty to take care even when they are not even born. So the mothers who are planning, so they must be preparing themselves accordingly. Thank you so much, sir. Let me just see quickly if we have some question I cannot see in the chat box. Well, but dietitian Vanita Tejwani has mentioned that in 7th month GDM is HbA1c is controlled to 6.5. Still insulin is needed.
Yeah, I see. When you say 6.5, we presume that this could be a pre-existing undiagnosed diabetes. When it's already in a non-pregnant state, we say above 6.5 is 6.5 and above is diabetes. So when you have someone coming to with 6.5, irrespective of the weeks of pregnancy, you are supposed to go insulin is the first drug of choice. But if you have obesity and insulin resistance, certainly, and if there is no contraindication for metformin, you can certainly give metformin also. But one should remember that metformin in type 2 diabetes, pre-existing patients, I'm not talking about GDM, in pre-existing type 2 diabetes, It is a weak drug. Even in GDM, it's a weak drug. It will have almost 50% of the women will be able to achieve their targets, glycemic targets of 90 and 120 on metformin alone. And the rest 50% will ultimately need insulin to achieve their targets as the pregnancy advances. So we should be knowing that as the pregnancy advances, blood sugar goes up. Today, I have not talked about the therapy part more. I have talked of more which is related to educator to deal with a person, government coming to you. I have not entered into the therapy part of pre-existing diabetes, like how the insulin doses are to be adjusted. All those things can be in some other lecture. Yeah. But certainly she will need insulin therapy. Better.
Thank you, sir. I hope, Vanita, you have got your response. So, sir, and the way you have said that we are more
Cheryl has some
eager
questions.
to.
Cheryl has some
I
questions.
just wanted to say thank you so much, sir, for for being our guide for today's webinar, and thank you so much for your very very valuable guidance and for your time. And I think whatever I have learned from in GDM has been from you. You've always been the torch bearer, the flag bearer for GDM, and you've been so passionate about it. In fact, I always quote your quote saying that GDM is the stress test to the beta cells in pregnancy. And
Yes.
that is one statement which has stayed with me, and I do say this every time I'm teaching my students or I'm speaking anywhere. So I think it's really an honor for us to have you with us, and thank you for always being there and blessing us.
Thank you very much. Thank you.
And we are surely looking forward to hear you again, sir, on the other aspects as well.
Anytime. I'm always available. And you have got now Kavita with you. So that's another, you are available 24/7 around me through her. So
Thank you so much, sir. So thank you for your valuable time and guidance for today's session. I hope participants have enjoyed this lecture thoroughly and you can definitely implement it accordingly, the teachings of sir. Now moving over to our another case-based discussion on management of GDM with preeclampsia. And for that, we have two very eminent personalities who have been working extensively in this field is Dr. Rutul Goklani and Dr. Kavita Gupta. And I would take the privilege to share their introduction as well. Just a second. So Dr. Rutul Goklani Thakkar is consultant diabetologist from Ahmedabad and chief diabetologist and managing director of HC Diabetes Center. Also, he is fellow in
Dr. Vijaya, the screen is not there.
Screen is not there? Okay, just a second.
No, it's a different.
Rutul, you're mute.
Is it visible now?
Yes.
Yes, Vijay.
So Dr. Rutul Goklani Thakkar is a consultant diabetologist, as I have mentioned, from Ahmedabad and a chief diabetologist and managing director at HC Diabetes Center. He is fellow in diabetes at Apollo Hospitals in Liverpool, UK, postgraduate in diabetes from Czech Republic, certified in diabetology, RSSDI. Also is NEC member of RSSDI and ex-secretary RSSDI Gujarat chapter, national convener D Genius Group for Diabetes in India, founder DiaConnect PSG, co-chair Diabetes in Women.
So Vijaya, I feel this is enough, and
I mean,
we can
the list is
move
endless,
forward.
actually. And
that's okay,
I
completely
take.
okay.
So it is our honor to introduce here Dr. Rutul, and we are very happy that you have accepted our invitation. And now moving over to our very own Dr. Kavita Gupta is also an executive committee member of IPN India Metabolic Syndrome and Nutrition Core Group, who is also the director head Department of Dietetics and Therapeutic Diabetes Education at Sunil's Diabetes Care and Research Center, Private Limited, Nagpur. She is also honorary secretary of IDA Nagpur chapter, joint secretary ADE. ISPE Ideal Program for Pediatric and Adolescent Diabetes Educators. Then she has presented various research papers at international and national conferences and has published articles and authored chapters in national journals and books. She is actively involved, conducts and participates in diabetes education program and diet exhibitions since 25 years. And believe me, the way she is an eminent speaker at various national and international conferences, the energy that she brings into her session, the energy that brings into her work is truly, truly commendable. And her special interest in type 1 diabetes, insulin pump and whatnot. She is a Satana awardee as well.
So I think, yeah,
2026.
we'll go to the case. I think that's something people are looking forward to. Thank you so
Yes.
much. And thank you, Ipin. Thank you, Shilpa, Mansi, Bijoya ma'am, everybody. Thank you so much for having us over here.
So very
Thank you
quickly,
very much.
without wasting much of time, let's look forward to the case-based discussion.
Should I share the screen on my side?
Yes, you can.
Yeah. Okay, great. So thank you very much, IPEN, Sunil Gupta sir, and everyone, Dipsy, Shalini ma'am, Kavita ma'am, for including us. This is very important
Thank
day.
you, Cheryl, as well. Thank you, Cheryl,
Yeah,
for
Cheryl.
bringing us all together
How
on
can I
one
forget
platform.
Cheryl? Thank you,
Yes.
everyone from IPEN for including us. This is very important day of National GDM Awareness Day and Professor V. Seshia's birthday. So for us being here and talking about GDM, it is privilege. And my talk is basically on GDM and preeclampsia along with Dr. Kavita Gupta. And our case is basically a woman with 29 years of age, secondary gravida, where second pregnancy. Her history, there is no history of gestational diabetes in first pregnancy. Current status is 25 weeks of gestation and 75-gram OGTT revealed and diagnosed her gestational diabetes with value of 180 milligram per deciliter, which was first time when she was diagnosed. And her BMI, pre-pregnancy BMI was 27. She has the most important thing here, comorbidity, is preeclampsia. And blood pressure is 140/90 right now. So what to do in such cases? First of all, we are looking forward to treat gestational diabetes first. So patients' postprandial blood sugar remained more than 120 milligram per deciliter after 2 weeks of MNT. And what are the next steps? So before starting, what are the next steps? This should be ideally very clinical thing. What steps we should take in such cases? Before that, I want to ask Dr. Kavita ma'am that what exact MNT would you prescribe, or the basics of MNT that you will explain to such kind of cases with preeclampsia and gestational diabetes? So and for how long will consider it as MNT failure?
Yes, so Dr. Rutul, the Government of India guidelines has specifically told that 2 weeks, in a typical GDM case, we will be giving 2 weeks of trial for on MNT, and MNT will be, yes, basically the main aim will be to achieve good glycemic control, so no hyperglycemia at all. And as Dr. Shalini has already told, fasting should be 90 and your postprandial should be 120 with that tight control. Appropriate maternal weight gain is very important, and appropriate fetal development at the same time and without causing any ketosis. So once all this is aimed at, and of course, when we are talking about MNT, we will be actually focusing on a nutrient-dense foods, what
Ma'am, you are not.
Lata Shashi ma'am has already told. We'll be switching, we'll be stopping absolutely no simple carbohydrates, no. Okay, I'll put my video off. So
Thank you.
absolutely no simple carbs. We'll be focusing only on complex carbohydrates. On that, yeah. So I think now it's better.
Yeah.
Yeah, so
You are
we'll be
audible, ma'am.
spreading, the complex carbohydrates over 3 small meals and 2 small snacks. And RDA specifically says that 175 grams of says that the carbohydrate intake should be 170 grams per day. So this specifically is very important, and ma'am has already specified about protein. Here in one fat, while talking about fat, when we're talking about pregnancy, one thing I just want to make clear that we can't allow a lot of fat intake, especially I've seen the mothers, you're pregnant, so aap ghee zyada kha lo. So trans fatty acids, because that will raise, in turn will also will increase the risk of macrosomia. So with all that, I think we will go ahead with MNT. If MNT doesn't work, yes, the role of physician starts.
Yes,
Along with
thank you very
exercise.
much. So
Yes.
thank you, ma'am, for wonderfully explain when MNT failure is there. This is what the important thing. 2 weeks, not more than that, we can give. And the most important thing in the diagnosis of GDM, pure GDM, is when you have 24 to 28 weeks. Your woman with diabetes, she is diagnosed. When she is diagnosed more than 24 weeks, and her blood glucose with OGTT, 75 gram OGTT, that could be non-fasting OGTT as well. And if it is more than 140, then you directly put her on MNT for at least 2 weeks. And if this MNT doesn't work, then we have next treatment plan. And in case of preeclampsia, what could be the treatment plan? So pharmacotherapy should be ideally initiated. While metformin is commonly used in all GDM cases after 20 weeks, insulin is definitely a gold standard. We have already heard this from Dr. Shalini Jaggi ma'am and Dr. Sunil Gupta sir as well, because insulin does not cross placenta. So in preeclampsia cases, this is the most important thing. In preeclampsia case, insulin is often preferred to ensure rapid, tight control and to avoid potential risk of renal stress from oral agents, as well as metformin also has a risk of low for gestational age. So LGA is also possible with metformin. So baby's birth weight could reduce due to metformin. This message should be clear, and it may cause birth growth restriction in fetus. This is why we should try to avoid metformin in hypertension or preeclampsia. This is the important message that we should give to everyone. So is metformin contraindicated? Yes, metformin is not completely contraindicated, but yes, relatively it is contraindicated, and you should be cautious. If patient is not ready to take insulin at all, then we may give in lower dose, but ideally we should give insulin in all cases with GDM and preeclampsia. So this is here summary.
So Dr. Uttul, in this case, you would be what would be your suggestion with the?
So I would definitely go for insulin. I feel pregnancy is the place where all the patients or the women, they are the most compliant. So I don't think that they deny for insulin if you explain them it thoroughly. If you go point by point and with evidence, if you explain them why should we take insulin and not metformin in your case, they will definitely accept it easily. This is what, but yes, you have to spend extra 2 to 3 minutes or 5 minutes with them to explaining everything in detail. So this is the summary table for treatment choice. So in a case of metformin and insulin, placental transfer, yes, metformin crosses placenta and insulin does not. Renal risk with metformin is definitely there, and risk of lactic acidosis is also there. It is usually not in routine cases that we found lactic acidosis, but yes, there are few of the cases. In blood pressure, it may cause IUGR, and insulin is neutral for that. And glycemic control may take time to titrate. 50% of them may need insulin, as Sunil Gupta sir was clearly explaining that even after starting metformin, 50% of our cases would fail to control their blood sugar with metformin alone. So we have to start metformin along with insulin. And in case of glycemic control, definitely infinite time insulin can control your blood sugar. So you can increase the dose of insulin as much as we want. So my next question is to Kavita ma'am. Does high protein take worsen pre-eclampsia related kidney stress? So in most of the cases, when we give the protein, the patients have this misconception or conception, whatever we can say, that they think that if we give protein, it may harm their kidney and they increase the kidney stress. So should we give extra protein to those patients or not?
Yes, so actually, Dr. Rutul, this case is a typical case of like a GDM with obesity in the second trimester, with preeclampsia and as well proteinuria. So, as contrary to CKD, what we believe here, because of the proteinuria, we will have to add protein. In fact, 1.2 grams, per day will be added, and that to a high biological value protein is always emphasized, because and believe me, I have seen beautiful results with egg whites. So the blood glucose also does not rise whenever you give with egg whites, or you can also give your lean dairy products can be given for a good fetal growth. So we need to emphasize on good quality protein. We do not have to reduce the protein intake, and basically she's in second trimester. So otherwise also in the second trimester, we increase 10 grams of protein, and in the third trimester, we increase around 20 to 22 grams of protein. So here we will be again increasing the good quality protein. And here I would just like to emphasize that, especially in the breakfast part, usually, if I'll just like to focus here on one thing, most of their patients, if being not this case, but in a GDM case specifically, they have increased insulin resistance, what clearly mentioned by Dr. Shalini as well. So splitting of meal is very, very important. We are actually used to eating very large sized breakfast, so we need to divide our breakfast, maybe a protein and a fiber first. So it can be a fistful of nuts with your yogurt, or it can be, or paneer chila, a moong dal chila or a besan chila with paneer. That could be a better option. And rather than having two chilas, it can be one chila, and maybe it can be divided after in two hours. So that for a good glycemic control.
Great. Thank you very much, ma'am. So this is the clear message that
Yes.
ideally protein should not be restricted, especially in our protein deficient country. As Indian, we are protein deficient in most of our diet. So this is why we should not restrict. So now this is what should be the BP targets. Blood pressure target according to new preeclampsia consensus. So this is the reference I have given, preeclampsia.org. In recent guidelines, what they have mentioned, that optimal target should be less than 135 by 85, and it should not be less than 120/80, which is normal for non-hypertensive, non-diabetic, and non-preeclampsia patient, but we should try to achieve less than 135 by 85. So clinical action for goal for medical nutrition therapy and medication both. So ideally, initiation of medication should be at point of 140 by 90, and if 160 by 110, then immediate hospitalization should be there. In case of medications at home, we can give labetalol, nifedipine, and methyl-dopa. Among them, labetalol and nifedipine is given in most of the cases. So treatment of choice is labetalol and nifedipine. So this is my question to Kavita ma'am. Why should we focus on low glycemic GI instead of just low carb? especially for our MNT cases. Even MNT is the base. Even if you are prescribing metformin or insulin, ideally we should focus more on low glycemic index and not just low carb. What does it mean, ma'am? And then how should we achieve this low glycemic index?
So quickly, what I have already told that the RDA already states that we need to 175 grams of carbohydrate. So we can't go very low on carbs because we need to have a good fetal neurodevelopment. Otherwise, the patient may land up into ketosis. So we need to choose low glycemic index food, which will give a good which will not spike your postprandial blood glucose. And that is what I think the whole scene is. We all of us are just focusing that the postprandial should not spike. So that is why choose on low glycemic foods so that we give good quality foods without starving the fetus and having a good amount of weight gain also, not a large weight gain, because again this is the BMI is raised, so we need to have only 5 to 9 kgs of weight gain in the whole trimester. I think we are just lack of time, so maybe I would just like to focus
so this
again.
is the right.
Maybe I just go on the pre-eclampsia part, sir, because
Yes, please.
it's
Yes,
already
please.
8:33.
Please,
So
please.
here, because the patient is pre-eclampsia, one thing I just want to focus on. Can we move on the next slides? Here, I just want to focus that we can give magnesium-rich food, sodium and potassium-rich foods, but here again, emphasis should be not very, whenever we talk about potassium-rich foods, people grab on bananas and coconut water. Again, if we, with bananas and coconut water, we are also looking at a good glycemic control. So yes, in pregnancy, in GDM, bananas should be a complete no, because I always tell them, please monitor your blood glucose, whatever fruits you're eating. I usually, ask them to switch over to citrus fruits, which is a good, better option. Yes, avoid sodium-rich processed bakery fruits, your papad, pickles, soy sauces, all has to be avoided, and no extra salt in your rice, in your atta. You have to exclusively use iodized salt. So no type of your kala namak or your lona salt, or no. Moderation is the key. That's very, very important. You need to go on adjuvants. You can go for adjuvants. You can go for, because food without salt does not taste good. So you can add your lemon, you can add your amchur, your black pepper. You must go for DASH diet. That's very, very important. Go on fresh fruits, not much of fruits, but yes, more of green leafy vegetables, and other vegetables, and more on grain, and low fat milk can be taken. And of course, there are studies which have shown that Mediterranean diet and DASH diet gives are very important, in reducing your blood pressures. So we can focus on Mediterranean, and
I think, ma'am, your voice is
focusing
not
more
clear.
on quality of that as well.
Right. So basically, balanced diet with low salt and or maybe no salt can be really helpful in
Low salt.
yes. Yes, could be really helpful in
Maybe
achieving
around
our
4
blood
grams.
pressure. Yes. So for blood sugar control, definitely what the clear message was to add fibers as well as giving the food which does not cause glycemic spike, especially postprandial glycemic spike, and they are low. They should not be too much low in carbohydrate, but ideally they should be low glycemic so that we do not get the spike. This is the clear message. And if we have any question, we would like to address those questions.
Thank you so much, Dr. Rutul and Dr. Kavita, for this excellent case discussion. people were, I mean, this preeclampsia, as it is already a concern, and with that, the diabetes, the very well, the all the areas has been covered. As we are running short of time, probably we can take up the questions at the end of another case discussion. I hope that is absolutely okay with you, Dr.
I
Rupul and
think
Dr.
you can take up questions for Dr. Rutul Bijoya now because,
Okay.
yeah, so we'll take up questions for them and then we'll come with the case.
Right.
As of now,
So,
any questions in the chat box?
There is
yeah.
the
So,
chat, yeah.
so we have one question. Yeah. Does a pre-diabetic woman of A1C 6.4 require insulin to get pregnant by Parvinder Kaur? So 6.4 is pre-pregnancy HbA1c, is it?
You are muted, Dr. Gupta.
No, I feel I'm not mute.
No, you are not muted. Dr. Kavita Gupta is muted.
Yeah.
Yeah. Should I take the question?
Yes, yes, yes.
Yes.
Dr.
So
Gupta.
HbA1c is 6.4 before pregnancy. So this is a clear case of pre-diabetes. So whenever it is a pre-diabetes, so Dr. Sunil Gupta also explained that IGT before pregnancy or in non-pregnant state is actually a GDM during pregnancy. So whenever we see 6.4, it is already a range of gestational diabetes already there. So yes, we should ideally start insulin if this woman get pregnant. So on very first day, we have to start insulin in because 6.4, it means average of 130 or 35. And in this woman will definitely have spike up even up to 160, 170 during pregnancy and post meal. And in fasting, she must have fasting plasma glucose more than 100 or 110. So we should start basal bolus therapy in such cases from very first day of the pregnancy. So diagnosed in 5th month, but patient family not willing to see diabetologist, they are insisting they will manage and control food and exercise and how to deal in such case by Dr. Vinita Tejwani. So I would say that you should convince her to visit diabetologist, endocrinologist for sure, because I feel if it is if she requires metformin or even insulin, they should consult. And I feel that you can't give more than 2 weeks of MNT, and ideally MNT even alone should not be prescribed by nutritionists and dietitians, and you should keep diabetologists in loop, and you should convince them to meet diabetologist. And I feel that women are always very compliant during pregnancy, and they will listen to you for sure.
Thank you, Dr. Rutul. Thank you so much. We have one more question that is for Dr. Kavita Gupta. This question is from dietitian Deepika Sharma. She has asked, ma'am, anemic patient, what should give to help for GDM patient? So that means if a GDM patient is also anemic, so what foods we give?
Yeah, we mostly see that cases. So of course, green leafy vegetables is the good source along with vitamin C is I'll just put off my list. So your iron, folic acid along with vitamin C has to be given to all the pregnant women, especially GDMs.
So now moving over to
Vijay, I'd just like to add anemia. Definitely do concentrate on the protein content of the diet also.
Yes.
If the protein is adequate, the iron absorption also is better because all these mothers are already on iron supplementation. So always concentrate on foods. You don't need to get to the dried fruits just because you need to give it for anemia. So even anemia and GDM, when they are GDM patients, the priority is glycemic control. So what has to be avoided? So the dried fruits has to be avoided. All the jaggery, if they want to take it, has to be avoided. So you can go in for nuts and seeds without any sweeteners. And as Kavita said, green leafy vegetables, specifically in pureed form or in a powdered form so that the absorption is better. And all non-heme ion sources, as we know, should go with the vitamin C. So concentrate on a good protein-based diet for better absorption of iron. Thank you.
Yes, absolutely. So, no further questions are there in the chat box. However, in between the discussion, if it comes up, then we would definitely be taking it up. So now moving
also
over.
see if
Yeah. So, Dr. Gupta, you were saying something?
no, I think we can just move ahead. We're getting
Okay.
late, actually.
So now moving over to our next very much awaited session on integrated approach to postpartum care. So we have seen before pre-pregnancy, pregnancy, now the postpartum. And for this, we are having eminent personalities with us. And I would be more than happy to share their introduction. Is my screen visible?
Can
Yes,
somebody?
Vijay. Yeah.
Yes, yes.
So now we have Dr. Dhruvi Hasnani, who is MD Physician FRCP, as a consultant diabetologist at Rudraksh Institute of Medical Sciences and HOD Clinical Research at RIMS Ahmedabad. She is also Joint Secretary for RSSDI Gujarat chapter and Secretary Indian Podiatry Association Gujarat chapter. And she has been winner of Torrent Young Scholar Award for Diabetes Outstanding Contribution to Diabetes Care, ACP Entrepreneur Award, Best Innovation in Diabetes Care, Rising Star. I mean, I'll get tired while taking the names of our awards. First of all, my heartiest congratulations to you, Dr. Dhruvi Hasnani, for achieving these heights. And you are
Thank you, ma'am.
truly inspiring us. And we are really looking forward to your session. And with you, it is going to complement by none other than my very dear friend, Ms. Cheryl Salis, who is not just a certified diabetes educator, Sadhana awardee, and an ISPAT Alan-Dresch Fellowship, but she is also only female from India, probably only Indian, in the Lancet Diabetes and Endocrinology Commissioner for the Type 1 Diabetes. She is also lead ISPAT Special Interest Group Nutrition, past faculty school, Science School for Healthcare Professionals ISPAT. She is also the Chief Program Officer for Metabolic Syndrome and Nutrition Core Group, IPN India, and has co-authored several and authored various publications, journals. Very good researches are coming up, and basically, who doesn't know Cheryl Salis when the name of the diabetes comes up, at least in our fraternity, I must say. So, and thank you so much, Cheryl, for arranging this beautiful session along with Dr. Kavita Gupta. I mean, like, it is brilliant to hear to each one of you, and we all have been absolutely hooked to our seats. So, over to both of you.
Thank you
Thank
so
you
much.
so much. Yeah, sure. I would like to thank you first for having me on board, the entire team of IPEN, Professor Bijoya, Sunil sir, Kavita ma'am, Dr. Lata, Shalini ma'am, of course, everybody who's been very instrumental in changing how we can give better care to female whose pregnancies are complicated with diabetes and hyperglycemia. Today, of course, is a wonderful day. All of us, wishing Professor Dr. Sheshaya sir a very happy birthday. I would also love to wish all my female sisters, all female friends, everybody a happy Women's Day. We've successfully delivered, babies of two cases. And between Cheryl and I, we decided that, we will continue with those cases. We will continue and talk to our audiences as to what happens after the baby is delivered. We have one half of the battle. The entire next process requires a lot more of our, multidisciplinary and integrated approach towards this lady, towards the child, and towards the next generation. So with that, I once again thank the entire team of IPEN and, for having me on board. Thank you, Cheryl. So I'll just briefly discuss Shalini ma'am's and Dr. Lata ma'am's case. She is an architect, a 29-year-old lady. She's a preemie, 7 weeks gestation. Some OBGYN did her DIPSI test and it turned out to be 154. No previous history of type 2 diabetes. She's only 29. A lot of us felt that a lot more counseling could help this lady. She had PCOS since the age of 15 years. We saw how robustly Lata ma'am and Shalini ma'am managed her. She did lose weight 3 years back, but of course obesity is a chronic disorder. Her father had type 2 diabetes, chronic arterial disease. She struggled with weight and whatnot. So, Cheryl, would you like to, ask me the first question and we'll go back and forth?
I think postpartum is always challenging because, like everybody agrees, GDM is, we have the most compliant person because she'll do anything and everything that you tell her because she wants the well-being of her child. But, once the baby delivers, she thinks, oh, now my diabetes is gone and I can now, eat. And of course, there's so much of pressure from your mother-in-law, etc., because then I always say you become like a milking cow. So, you're actually fed because you can, you get more milk. And this is typically what we see a day in and day out. So after delivery, I mean, my question to you, Dr. Dhruvi, is after delivery, insulin resistance rapidly falls. So how should clinicians approach the de-intensification or transition of therapy in women with pre-existing type 2 diabetes? And when should be insulin continued versus switching to oral agents? Because this is one question that is often asked.
So it's absolutely amazing about what you said, females, the entire family, everybody is concentrating on the baby. The lady, she's going through so many hormonal changes at this point of time. Scientifically and medically, clinically, once you deliver the placenta, you deliver the child, the removal of all of these hormones, progesterone, HPL, cortisol, once all of these try to go back to the normal physiological levels, there is a rapid reduction in the insulin resistance, which also leads to a rapid reduction in the requirement of insulin for this lady, which is almost 30 to 50%. So, say for example, somebody required an insulin level or total daily dose of insulin at say 70 units or 60 units. The requirement post delivery will come down to half of say only 30 or 25 units. Also, the lady in the first couple of days of delivery, she's not able to eat well. A lot of people want to push her to eat, but she's not able to eat well. Other than this insulin requirement, what we also need to understand is for a lot of females, like this lady who had a pre-existing type 2 diabetes, nobody must have counseled her in a pre-conception phase. For this lady, it is very important for us, again, for the nutritionist and for us as diabetes to come together to explain it to her when to monitor her sugars. It is not the end of when you stop to take care of yourself. Along with the child, you have to take care of yourself even more fervently. CGM use, technology use can be very, very beneficial. SMBG, of course, we do de-intensify the SMBG frequency from 5 point or 7 point. We do ask her to only monitor herself twice in a day, but that is still required. Something which I would, really want to ask Cheryl, but talk about lactation first in terms of insulin requirement again. The more frequently a mother lactates and feeds the child, the better is the insulin sensitivity. The lower is the insulin dose requirement. And again, I'll request Cheryl to talk about how the smaller, carbohydrate feeding or smaller snacking is required. But the transition back from insulin to oral therapy is what is crucial, which will only come from monitoring, which will only come, when that lady has been appropriately following the nutritionist's advice. Metformin is safe during lactation, but insulin is the preferred mode in case there is this glycemia which with a lot of glycemic variability. So my answer and my question back to Cheryl again, I'll shift the focus to you for nutrition. They would want to eat gon laddus, they would want to eat ghee, everybody would want to feed them with so much of high calorie diet. This lady is sleep deprived, she is exhausted. What would be a very practical dietary framework, Cheryl, that we would want to advocate for in terms of sugar control, glycemic control, in terms of the breastfeeding necessities, and also in terms of weight management?
Yeah, I think that's a very good question. And like we said, the focus is all on the baby. And we always tell, when the families come, especially when the husband comes, that please, also ask the woman, how is she feeling? Make sure you're a part of the entire thing, especially once the baby is fed, then make sure you are taking the baby to burp the baby so that she gets that much needed rest. Because, it's like, you're constantly, and we also know about postpartum depression. So that is also a reality in a woman's life, especially after she delivers. And again, she's put on so much weight that, she starts not feeling good about her own body because she thinks that she'll lose all the weight once she delivers, but that weight has not gone anywhere. It is there, which is leading to further problems. So I think our job actually starts here more. And this is where we always find a concern, is because they go lost to follow up. We don't really know what is happening. And like we say, agree, that once they deliver, they feel I can eat everything. I don't really need to worry. And they go on a binge, and there's so much of pressure. So, the mother or the mother-in-law wants them to finish that 15 kilo ghee dabba, and there'll be methi laddus, and there'll be goan laddus, and there'll be panjeri, depending on which part of the country you come from. So of course, one is very important, is we have to encourage breastfeeding, because that is, that itself will help the mother lose weight, because it's a very high calorie expending activity. Secondly, the more the suckling that the baby does, the better is the breast feed that will come. So that is another important thing. And of course, there are certain foods which do help and promote. So we have to encourage those foods in the diet. For example, and you really doesn't need to be very carb heavy or calorie heavy. Very simple, like garlic, methi. So, you can make like a methi kanji, or just soak methi in water and have that. Then you have, certain indigestion or bloating or certain things. And we give them, jeera soft pani or ajwain. We give them a mukwas, which is got dil seeds, which is suwa. And that's a very common, mukwas that we all eat. So it's basically suwa with, soft and ajwain. Iska, you can make a mixture and have that immediately after meals, or make a water out of it and have. So these are things. Then makhana is something which is popular and advocated again. So we can give them that as snacks, because especially before they are breastfeeding, we always tell them that have a snack which has got a good combination of carbs and protein. So that is extremely important, because like we said, it is a calorie expending activity, and sometimes, they may start feeling low. Especially if we are on insulin, etc., we don't want the hypoglycemia to happen. And therefore, we always tell them to have that with a glass of water. So hydration is also very, very important. And have a balanced diet. I think we all focus. And again, lactation is not the time to diet. At least the first 6 months, the woman wants to go on to a diet on the very next day, which is not what we advocate. We encourage that you eat a balanced diet, your home cooked meals, have a good combination of, your low GI carbs, your lente carbs, with a good amount of protein, because your protein requirements are still high during lactation. Okay, your
I want to ask you a follow-up question. I'll interrupt you, but not everybody is so conscious. I have a practice in a suburban and a rural area also, and females really are so misguided onto the fact of nutrition. They feel that this is the only time, probably, when their family will, fulfill their wishes and the food, let's say cravings, or any demands. What do you have to? How do you counsel these females at that
same thing. So we would obviously, when we see a person, we will take their dietary recall, that what they are doing currently. We also looked at whether it is culturally appropriate. What is the family been eating? What
time?
are the likes and dislikes? What do they feel like eating? And then plan the diet. So that is of course a given that we would do. But while doing that, we will try and follow that we actually like give good quality carbs, moderate the carbs, ensure there's protein in every meal. So at least the main meals having protein, and even the in between snacks, a good combination, especially if they're breastfeeding, then a good combination of carb and protein and hydration. So this is something that we would ensure that they have. For example, instead of panjeri, which is a very famous thing in north of India that they would have, we would tell them to either cut down the jaggery or the wheat flour, have nuts and seeds with milk. So that's a thing. If they can make a methi kanji, or even if they want to make a methi laddu, then have it with lesser amount of jaggery, put some nuts like almonds, etc., and then have it before the breastfeeding, because that would help them. And make sure they're adequately rested, because if they're not rested, that itself is going to deter the entire thing. So we always encourage the family to allow, or when the child is sleeping, even the mother should try and catch up on sleep, so that she gets that much needed sleep that is required. And of course, green leafy vegetables, your ragi or nachni. These are things that are, of course, that we add into the diet, all your calcium rich foods, iron rich foods. So these are things which are non-negotiable in the diet.
Well, that's really wonderful when you put it, and it does seem a very important period wherein we can intervene so that that lady as well as the family is educated, and taught about the long term diabetes progression, especially for this lady who was having a history of PCOS. She came with a very early on early onset gestational diabetes, or might be having a pre-existing type 2 diabetes. Now, I'll ask you from a nutrition point of view, what are some integrated strategies that could combine the physical activity, nutrition, and the glucose monitoring part to prevent the long-term diabetes progression in these females?
So one very important thing is again physical activity, because what happens is once the woman delivers, and I have experienced personally, first
Mm,
40 days you're not even allowed to go out, and then you are just in the house, or you're not really moving about. So we always
mm,
encourage them to be as physically active as possible. Take
mhm,
those, what we call as exercise snacking breaks. So those are important, and then encourage them to incorporate physical activity as a part of their day-to-day life, because that itself will help prevent diabetes, and in the long run, and also prevent gestational diabetes. We can definitely
mhm,
try at doing that. Nutrition, of course, we try and give them a balanced diet, and I think somewhere there has to be a follow-up mechanism. What actually
mhm.
is the problem is their poor adherence because of no follow-up. Person doesn't
Yeah.
really come back to you. And we have the wings mostly study, which was done by Dr. Mohan and Dr. Uma, where they've clearly shown that when you actually do follow-ups, through maybe telephone calls or WhatsApp reminders, etc., the adherence is better, and the compliance is very, very good. So this is something that maybe as a nutritionist, as a diabetologist, we can incorporate into our practice. So if you're actually following up and telling them, it's time to come, maybe every 6 months or every year, and why it's so important to keep monitoring and
Mm.
screen. And I'm sure I would like to know your inputs on this as well, because it's so important that how would you manage a person who's, you've been managing through pregnancy, and then postmortem, what is your approach to make sure that you are regularly in touch with them?
The most practical thing that I do is I ask the mother and the mother-in-law both to sit together with that lady, and I give them some very basic and simple targets that in the coming 6 months to 12 months, let us first try and achieve a very normoglycemia. The second target is, going back to a weight which was the pre-pregnancy weight. If she is able to, breastfeed very normally, if there is no trouble with her lactation, I will include my nutritionist as the largest part to talk to both these women who are very important in this lady's life, to help her manage the child so that she gets a proper break. She can sleep well, she can eat well. Physical activity, like you said, if it is a normal vaginal delivery, I really ask the lady that after 2 weeks, please try and do your routine work or your routine strolls, or go back to the 115 minutes per week sort of a very light to moderate exercises which you are comfortable with. For somebody undergoing a C-section, I ask them to wait for at least 3 to 4 weeks, and then ask them to go back to their physical activity or the routine physical exercises. Glucose monitoring again is a very important part of the counseling that we give. Of course, de-intensifying the frequency of SMBG, if they are able to do a CGM for every person or every lady, CGM is what I recommend. If they are not able to do, of course, SMBG twice in a day, but a 6 weeks OGTT is something that I ask them not to miss. And a pediatrician, whosoever, is going to be looking at that child, is also somebody who is roped in through my team. And our nutritionist will call the lady up at 6 weeks and ask her whether you've done your OGTT, or if not, just send us your SMBJ readings at 6 weeks. And again, at 6 months, that's a very important part, to repeat the HbA1c, to repeat the OGTT, or still continue with SMBG in case there was any sort of a dysglycemia, which could be the case for this particular case that we took a 29-year-old female who might be 30 by now after delivering their child. And again, a nutritionist role cannot be negated. She will be the lady that the lady will come back to, or she'll be the person the lady will come back to for any sort of safe questioning. With a doctor, sometimes they feel that मैं ये नहीं पूछ सकती, With a nutritionist, they feel I can ask, मैं मुरमुरा खा सकती हूँ, can I have an ice cream? I have this craving, help me with that. And again, it's so important for all our audiences to hear and understand that you are not just a nutritionist for that lady, you are somebody who she is confiding in at this point of time. So yes, and a long-term diabetes prevention also starts with monitoring of weight, monitoring of her blood pressure, 6 monthly doing her HbA1c if they are deranged, and putting her on a good lifestyle intervention after 6 months postpartum. And this is what I would do. Please add something if I've missed.
I think that's a very good jugalbandi that you'll have, you and your nutritionist. And I think that is so important, working together as a team. And I think everybody here, all the panelists have emphasized on that it is something that is teamwork and we have to work together because this woman, often what happens is like, life takes over and your priority becomes your child and then getting back to work and, getting back to routine. And often you neglect yourself. And then within the next few years, you realize, oh my God, I've gained so much weight, I've got diabetes now. And then it's a situation where it's very difficult then to manage. So I think sitting down with them, right when they are, what we do at least in our clinic is when they are pregnant itself, we prime them and we tell them how important it is for them to, post once they deliver, especially if they do not want to get diabetes. And we always encourage, I mean, I'm talking about breastfeeding again, but we know that breastfeeding is associated even with lower incidence of childhood obesity and diabetes. So we encourage them to breastfeed as much as possible. And we also tell them that lactation is not the time for severe calorie restriction because that will cause more fatigue, more nutritional deficiencies, and you're not really going to give the right nutrition to your baby. So emphasizing on eating a balanced home cooked diet. And of course, if you want to cheat, we follow the 80-20 principle. 80% of the time you eat your, good home cooked food. And then 20% of the time you want to indulge, yes, but without doubt, you have to do your physical activity. And that's where Shatapavali comes in. We tell them at least 100 steps. If nothing, then at least 100 steps after every meal. If you can do that much, or take 10 minutes after every meal, break it up. And sometimes, they are, once they realize that it's not so difficult, it's not so complicated, then we definitely get their buy-in and they're ready to do it. But yes, we need to focus on it.
Well, that was wonderful for the first case. I think the lady will turn up healthy, and we will talk about, maybe see her follow up next. I'll move on to Kavita ma'am's case and Dr. Rutul's case. Again, she was 29-year-old, but she was a second gravida. She was having a second pregnancy. No history of GDM in the first pregnancy. Her current status was 25 weeks of gestation. Pre-pregnancy BMI being 27. GDM was diagnosed, a true GDM, via the DIPSI method. The 2-hour post glucose test was showing 180, comorbidity of preeclampsia, proteinuria, and again, I don't know why I kept my question first if I was presenting the case, but of course.
Fine, but what should be the structured postpartum screening protocol for women with GDM? I think the timing of OGTT, the frequency of follow-up, and again, diagnosing persistent dysglycemia and also hypertension.
Absolutely. So thank you so much. And like we just discussed, the postpartum screening protocol is a very important one. A 6 weeks OGTT followed by a 6 months OGTT plus an HbA1c is what is of utmost necessity. Along with that, blood pressure monitoring as often as possible. Home blood pressure, ambulatory blood pressure monitoring is what we recommend to anybody diagnosed with preeclampsia. Along with that, whenever blood reports are done, which is at 1 month or 6 weeks, whichever the earlier that the lady can do, followed by 3 months and then 6 months doing a short metabolic panel, including a creatinine, a lipid profile, a normal hemogram is what is advised for this lady because she already, along with true GDM, she did have proteinuria, a urine albumin creatinine ratio, something important, and a fundus which we did not discuss in the previous time for this lady. And I understand that is something that we need to do if this lady has hypertension, preeclampsia, or proteinuria along with a GDM, diagnosis. The frequency of follow-up is again quite easy to understand. It is at 6 weeks, 3 months and then 6 months. It could be at your own discretion if the lady is agreeing to come and if she's in the same city. A lot of females go back and migrate back to their sasural, go back with the child, and it is important that either you refer them to a very competent team of diabeto and a nutritionist or do a telephonic follow-up with that lady. The criteria of diagnosis for dysglycemia goes back to a non-diabetic person or non-pregnant levels. The fasting has to be less than 126. Her postprandial has to be less than 200. We again categorize her HbA1c into, a pre-diabetic diabetes state where 6.4 is the cutoff, 6.4 and plus she is a diabetic person, 5.7 to 6.4 is pre-diabetes, and we want to use this non-pregnant criteria for this lady postpartum and post-delivery. Blood pressure targets, Dr. Rutul mentioned very correctly, but we use the cutoffs as 130 and 80 mmHg and not 135 and 80. And in an Indian context, Kavita ma'am very beautifully talked about the salt restriction, but still it is needed to be there in a proper dose. I think I'm covering a lot when I'm saying all of this.
I just
Right?
wanted to add, while you were talking, it just struck me. What if we have maybe some kind of a mechanism, because they'll always go to a pediatrician.
There we
Maybe there is where also you can catch them. So it's like if they don't come to you, you have a mechanism where they check their body, their weight and their maybe blood glucose levels, HbA1c at the pediatrician clinic. So have like those camps. And that is where at least, because that is something they don't miss. They have to go for their vaccinations or follow-ups. And that way is, I think that will be brilliant if we have also a pediatrician in our team who is equally, geared up to prevent this lady from developing diabetes. I catch her wherever
We do
it's
have
possible.
that, Cheryl, actually. And that's what I think Dr. Yagnik sir's, long-term follow-up study, I don't remember the name right now, but that's what he did. He included the pediatricians. But the trouble is the women going back to their sasural. It might not happen too much in the metros and tier 1, but in the tier 2, tier 3 cities, it does happen that the lady goes away and to her husband's house, and of course, including a pediatrician would be a wonderful idea. At least let's start from that wherever possible.
In my mind that wherever we can catch them.
Absolutely. So now my question to you is, once this woman with GDM has reverted back to her normal glucose levels after the delivery, there still remains a high risk for the future of diabetes. What dietary patterns, what behavioral habits should we encourage, not just for the lady, but for the family to reduce that progression to type 2 diabetes?
I think intensive lifestyle management, it's very, very crucial. She has to understand that one is keeping the body weight in check, but more, I think, in our country, it's adiposity. So, making sure that she is well within her body composition levels, because that insulin resistance, like I was just discussing, that Dr. Sunil Gupta sir always says, that GDM is the stress test to your beta cells. It is so beautiful because that time only you get to know that, you do not have enough insulin reserve. So you need to preserve whatever it is possible, and therefore putting less load and making sure that you're improving insulin sensitivity becomes so crucial. So the right balanced diet, nutrition, there are a lot of myths and misconceptions that eat a very heavy breakfast, and we know that we're already so insulin resistant, and on that eat a very high GI/GL breakfast that itself increases our postprandial blood glucose levels, and throughout the day your sugars are on the higher side. So increase more protein, and today I think we all agree, and we have a lot of simple things. For example, you have a chilla or a pudla or a pesarattu, in different parts of the country. So we do have our low GI options. We don't really need very expensive exotic foods to be incorporated, because we do have people who come from rural areas, from slums, and it should be something that which is affordable, which is sustainable, and which the entire family can implement. And of course, if the mother is going to eat healthy, she's automatically going to ensure that her child also, because the child learns from their parents. So you're automatically tuning the children to also eat healthy, and you're going to, it's going to affect generations to come. So very important is what the parents eat. as a family. So, that is something that we need to focus on, is changing the habits of the family. Sleep is something that we see is highly compromised in today's times and age. People are hardly sleeping, they're binging on Netflix, or they're doom scrolling, and especially mothers, because whole day they can't look at their phone. So in the night when the child is sleeping is the time when they are on their phone. And sometimes we have the fathers who come, the husbands who come and say that, and inside the blanket and the mother is on the phone, like she's so addicted, and then she's not getting her sleep, maybe 3 hours, 2 hours, of maybe 4 hours, because morning you have to get up. And that itself is actually going to cause more, obesity, insulin resistance, and all the other lifestyle diseases. So I think every aspect needs to be managed. Again, stress management, maybe breathing, pranayam, doing some kind of meditation, because it is not easy, and especially in today's day and age, managing children itself, you need a lot of stress relaxation techniques, etc. And I think, again, activity, like you really said, 150 minutes to 300 minutes per week is non-negotiable. So it has to find time, because often they will always compromise on their time, their activity time for their children, etc., etc. So giving them those easy tips, I think that makes, and hydration, making sure that they're hydrated well and doing their routine checkups is so, so important.
So I'll still continue and ask you my next question, which is one of the last question for our cases. Could you simply point out, 3 points which are simple, culturally adaptable strategies that these mothers can follow for a sustainable, healthy eating? Because they are going to put themselves on the, back burner. The child takes the priority, and even the husbands complain that the child is a priority now. Tell us 3 strategies that in the first year of postpartum that lady can follow.
So one very important thing is, again, the plate method. So half your plate is non-starchy vegetables, 1/4 of your plate cereals, millets, which is our thali. So simple thali, but eating in, of course, whatever is recommended depending on what are the requirements. Because like I said, in lactation also, your nutrition requirements are slightly higher in terms of calories and protein. But following the plate method, following the food order, starting with protein and fiber first, because that will ensure there's fiber and protein in every meal. So that itself will help to blunt the GI as well as lower the GL of the meal. And then the snacking in between, because sometimes, they're just mindlessly snacking. So watching their portions and what they're eating, especially in a lady who's also at risk for high blood pressure or hypertension, then making sure that she's not snacking on the biscuits and namkeens, etc. And, giving her healthier options and, fruits and nuts, or makhana with nuts, etc. Or whatever is affordable and economical. I think that, like I said, at least if nothing, then Shatapavli, that is 100 steps after breakfast, 100 steps after lunch and dinner. And, after 8, 9 in the night, like close your kitchen, like that used to be done in the past. After 7, the kitchens used to be shut. But today our kitchens are open till 1 o'clock in the night. People
We
are
start at 7. Some
start
of
at
us may be
7, yeah.
eating today.
So at least try and eat by say 8, 8:30 if possible, and then don't eat. So at least if you do these things, which are simple, which are easily implementable, and that itself is good enough. You don't need to do anything drastic. And if you breastfeed the baby well, then automatically you are going to lose weight and be physically active as much. Keep increasing your NEAT, non-energy, non-exercise activity thermogenesis.
Right. So there's this one study, Cheryl, that says that in the first year of postpartum itself, a lady with GDM has 7 times more chances, 7 to 10 times more chances of developing type 2 diabetes if she's not taking care of herself appropriately through appropriate lifestyle modification benefits. Um, what I feel is still a family inclusive approach, which we miss most of the times, and the entire family wants to only nag her कि आप ये मत खाओ आप वो मत खाओ, you've got diabetes, you were diagnosed at some point of time, and she might also be going through a state of depression, the postpartum depression, the hormonal changes again, and it's a very emotional time for the female as well. So a very family inclusive behavioral changes, I feel, uh, can be made. I'm sure that it's not 100% applicable thing ever, but maybe telling the father that you eat what she has to eat, or maybe the in-laws are told that, it is an entire family intervention. There is no diabetic diet. It is something which is a healthy diet that all of you have to follow. And probably, having some exercises which are baby inclusive. We see so many videos. I also doom scroll sometimes, and we see so many videos wherein the infant starts to exercise because the mother has started to exercise. So if a lot more females see this more often, because not everybody is exposed to a very advanced or an open culture, but if females see this more often, that they can do this and they should do this, which will benefit them as well as the child, because the child is also at an equal risk of developing dysglycemia in her teenage, or obesity in the early adolescence. If I think the child's health is used as a way to educate the female, do you think that the mother will be more susceptible to the changes we are seeing?
And I think also involving the mother and the mother-in-law. I think having like you said, the family, because everybody has their own opinion, and that
Mhm.
kilo ka ghee dabba has to be over, and that is again, and then there are so many things that the mother should not eat because it'll affect the baby.
True.
The baby will get cold if you have this. There's so many misconceptions, I think, around pregnancy and around lactation, and these are things that we need to bust. And I think we can all do that as a fraternity, as all the associations coming together, I think that will be great, because there's so many myths and misconceptions which are there. And yeah, I think that would be a great approach to do, and telling them you just need to eat this much. And what exactly, if I'm saying 500 calories more, then what does it mean? What is that 500 calories? It
So
doesn't
what
really
does it
amount.
look like? Like, I myself might need your help in telling me what is a 500.
You don't need to eat like for two people, because typically they think, whether it's pregnancy or whether it's lactation, you need to eat for two people. You don't. It's just another, say, 500 to 600 calories extra. It's an additional amount of protein, which could be around, say, 10 to 13 or, grams of protein extra. But of course, we are protein deficient, so we have to make sure there's protein in every meal. And even our snacks have got protein. So I think we've had a wonderful discussion, and hopefully our participants who have joined us are
True.
excited about taking back all the knowledge back to their practice.
But any conclusive remarks on the integrated postpartum care?
Yeah, I think very, very. I don't know if Kavita wants to say something.
Yes, ma'am.
I think exclusive breastfeeding for that 6 months, that's very, very important, the mother, and it will also save mother from getting into diabetic in coming years. So yes, breastfeeding is very, very important. And of course, monitoring, whether it is your blood glucose, whether it is your blood pressure, monitoring is very, very important.
Yeah. I think we have a few questions. I don't know, Bijoya is, I think, left.
Yeah, I think Bijoya just told me that she had to leave because she had some prior appointments.
Okay. So I'm just going to quickly take, very quickly, are nutritional supplements advised in pregnancy is one of the questions, especially GDM and preeclampsia. So Dr. Kavita, you want to take that up?
Yes. So I have mostly seen that most of the gynecologists usually prescribe this your high protein powders. But what I suggest, if we have to increase only 10 grams in the second trimester, so first trimester we do not have to increase anything. Of course, we look into the dietary recall and everything, but in increasing only 10 grams, I think just increasing good quality protein by your 2 glasses of milk or a fistful of nuts, I think maybe a big bowl of a yogurt would match up with 10 grams, and 20 grams again, adding a nice big bowl of dal or sprouts or your legumes would give you lentil carbs and also would give you fiber and protein. I think that would match. But yes, if due to your hyperemesis gravidae, if they are not able to eat, mostly all these pregnant women, they are not able to consume dal, especially in the first trimester. So at that period, yes, you can add some protein supplements can be added. But of course, you have to make sure that they are zero sugars.
I think somebody had a question on if the mother can't really breastfeed, sometimes you don't get enough feed. So then what do you do? Dr. Lata, you want to take that question up?
Definitely. So the question says, is it possible that after the mother quits breastfeeding, she may develop diabetes? Is that the question you said?
Yes.
Okay.
Generally, I mean, somebody can't breastfeed. Obviously, she's not getting enough. So then what is the solution there?
No, this question is not from the, I think Vanita doesn't want to know
I've
from
clubbed two
protein, right?
questions. I've clubbed two questions and I'm asking you.
Okay. So from the protein content, definitely what Dr. Kavita just mentioned, there's no reason that we need to go on for any supplement. It can absolutely be met from a balanced diet with, just as all of us have been telling, including a good quality protein at every meal. So that way, the total protein intake would be sufficient. Yet, if we still need, because our assessment says that there's an inadequacy, then definitely go in for a no added sugar protein supplement, and for that brief period till they can take on. Now, from point of breastfeeding, just because the baby is not suckling enough or for reasons and then they're not, the point that we are talking of is, will it help in limiting or diabetes, because we're talking of breastfeeding is always better. So here also, on a dietary end, always continue with the low GI diets that we are always recommending on, low glycemic index diets with protein and fiber coming in at every meal, and all the galactogogues or whatever we are using in going in with taking care of the diabetic glycemic control principles. That would be the best to take them through this phase of 6 months of lactation.
Yeah.
I would just like to add that it's not the quitting of breastfeeding that leads to detection of diabetes. It is, of course, a lot of hormonal changes that could have been the reason why she's not able to properly lactate. The same pathophysiology also leads to insulin resistance, and a persistent insulin resistance or the dysglycemia could have continued postpartum as well. That could lead to turning into a full-fledged type 2 diabetes. And again, it is lifestyle modification that will benefit this lady much more than anything else. So it's not her fault. It's not the breastfeeding which is the trouble. No.
Yeah.
Thanks, Dr. Jogi.
Let's take
Right.
the last question now, which is on artificial sweeteners. Maybe Dr. Kavita can take this. That can a mother, use artificial sweeteners?
So if you FDA has clearly approved few artificial sweeteners, so your stevia, your sucralose, aspartame, S-sulfam, potassium has been approved. However, it is not approved. But what if in my suggestion as a nutritionist, I usually do not support artificial sweeteners for a pregnant woman. I give them, just in case if they wish to, yes, they can have one khajur or maybe, something in a natural form. But again, they have to monitor their blood glucose. That's the underline, they have to check their 6 point and 7 point monitoring has to be done.
Dr. Lata, you want to add anything?
Yes, I agree with that. Definitely, the first line would be if we can avoid artificial sweeteners. Not that we don't have a cutoff. If they still need to take it, I would actually ask them to use it in their beverages and nothing more than that, and not for excess use. Definitely, if they just stand, they tell that they cannot take their milk and they still need to, must be there, it would come in, but otherwise, we can still give all our natural means of sweetening or adding on. There are various ways that we can still allow without the artificial sweeteners, but yes, within the limits, it's safe.
But
As,
cardamom and all of that, it tastes very nice, and that itself is great. I think due to the paucity of time, I think we can just I will just give the vote of thanks. And just to summarize, I think it should be as close to what they would, their real diet, not to make it too complicated, and keep it very simple. But very important is focus on follow-ups, regular follow-ups, and nutrition, physical activity, sleep, stress management, and of course, family approach and pharmacotherapy. All of this is so important when it comes. And I think the whole jugalbandi of a diabetologist along with, the nutritionist, and now we've also got the pediatrician and everybody else into the picture. I think that will itself help, because, it's so important that we focus on this woman. And while the girl is pregnant, of course, we are focusing on the fetus of the future. So on that note, I think we've had a great academic feast. We didn't even realize that, how the time passed. It's 9:25 and we're supposed to finish at 8:45, but we got so passionate about the topic. And I mean, we've had a great academic feast, and I would first like to thank all of you. I mean, it was just a message to each one of you, and you all very easily agreed. I think it was wonderful, excellent. I think I couldn't have asked for a better team coming together, all stalwarts in the field, coming together on such an important day. I think a true tribute to our living legend, which is Professor Sheshaya, on National GDM Awareness Day. And I think we all have a huge role to play in terms of going out and educating and empowering people, and at least preventing GDM and managing GDM, and then preventing diabetes in the near future. Thank you to all the associations, DIPSI, PSG India, Diabetes Care Foundation of India, and on behalf of the chief program officers and the founding members of the IPEN Metabolic Syndrome Nutrition Core Group. I think it's thanks to all our eminent faculty. I think Dr. Sunil Gupta sir, Dr. Rutul, Dr. Dhruvi, Dr. Lata, Dr. Kavita Gupta. I mean, huge support, each one of you, right from helping me make the brochures to, and not to forget, I think RX Events, Hardik, Neelam, Jignesh, for all their support in making sure that this event happens, and are very enthusiastic and participative delegates. We've had great questions come from them. I'm getting a lot of messages from people. They're really enjoying the discussion. So thank you so much to each one of you who logged in, and it's been wonderful. And I think it's really time for all of us to work together. And one is fitness for pregnancy, and also focus on the fetus of the future. So thank you so much, everyone.
Yeah, and Dr. Bijoy has also extended her thanks, and she's sent me her entire vote of thanks. But I think that was the same thing what Cheryl has given. So thank you, everyone.
Thank you, Kavita ma'am. Thank you. It was you who called up, and I'm really very grateful for you thinking of me always and involving me. Thank you.
Thank you.
Thanks to Cheryl and Dr. Kavita. Excellent. Thank you so much.
I think
Yes, thank you. It was a wonderful session, and we thoroughly enjoyed. And it's already 9:30. Time to go home.
but the time passed.
Yes, bye-bye.
Thank you.